We are live.
Hello, good morning, everyone. I welcome you all to the fourth episode of GuruSangam 24-25 edition. I'm Dr. Tinku Bali and I'll be your moderator for this episode. Well, Guru Sangam was a program that was initiated last year and was very well received. So, through Guru Sangam, we invite distinguished teachers, all experts in their field, to lecture on a subject of their choice, keeping the postgraduates in mind. So, through Guru Sangam, we give you lectures which act as a repository of knowledge for times to come. As you can always go back to the AIOS YouTube channel and you can go back to these lectures and see them. So, through Guru Sangam, we hope to educate, elevate, and excel. With that, I welcome all our speakers and our panelists, and also the audience that has logged in today. Thank you all for being with us on this Sunday morning. So I'd like to thank the chairman of AIOS, Dr. Samar Basak, who's been very supportive of this program. The program directors, Dr. Santosh Honawar and Dr. Manoj Mathur, whose inputs have gone a long way in bringing this program forward. With that, I introduce you to our expert panel this morning. We have Dr. Bhaskar Srinivasan, the medical director of the Code Eye Care Chennai, Dr. Jayesh Wazirani, the director of the Excel Eye Care Ahmedabad, Dr. Vanati, who's a professor at the RP Center, AIMS, New Delhi, and a specialist in the cornea, refractive, and cataract services, and Dr. Vinay Pillai, who's the head of cornea and refractive services at the Giridhar Eye Institute, Kochi. So, a very warm welcome to you all, and I really look forward to your comments and inputs at the end of the talks. With that, we move on to our first speaker, who's Dr. Bhavna Sharma, who's the professor and head of ophthalmology at AIMS Bhopal. And to give you a short introduction of Dr. Bhavna, she specializes in cornea, ocular surface, and cataract. And apart from being a professor, she's also the Dean of Examination at the All India Institute of Medical Sciences, Bhopal. After her undergraduation and post-graduation from the Regional Institute of Ophthalmology, Bhopal, she went on to train in cornea and cataract at Dr. R.P. Center, AIMS, New Delhi. A prolific writer and researcher, she has authored more than 100 publications in international and national journals, chapters in various textbooks, and also a textbook on corneal emergencies. A recipient of various awards, including the Best of Best Paper Award in the State Conference, the Achievement Award by the All India Ophthalmic Society, the Honor Award of IGO, and the Shushruth Samman by the Forum of Ophthalmic Teachers of India. She's also on the editorial board as well as a reviewer for various peer-reviewed ophthalmic journals. She has served as Vice President, Treasurer, and General Secretary of the Divisional Ophthalmic Societies, in addition to Chair of various institutional and government committees. So, welcome, Dr. Bhavna. And with that excellent academic background, Dr. Bhavna will be speaking to us on managing VKC, a child's game. So, over to you and looking forward to your talk. I'll stop sharing.
Thank you, Dr. Tinku, and I'm thankful to AIOS for giving me this opportunity to speak today on this forum. I would be speaking on management of VKC. And VKC is a fairly common disease entity which we come across, and of course the PG students. And a case like this, where a PG, you identify a case of a presenile cataract in a pediatric patient, and we are very quick to diagnose it as a developmental cataract. But also should be looked that the subtle signs of inflammation, which can be seen here, and this is because of a long duration of topical steroids which has been taken by this patient, leading to steroid-induced cataract. And similar condition here, a case of ciliary staphyloma in a patient of VKC. So steroids are not always the only treatment for vernal keratoconjunctivitis. And I would be speaking on management of vernal keratoconjunctivitis. Of course, it is not a child's game. Till the time that you know that about the disease entity, various types, what are the differentials and pathophysiology, the clinical features, and we would take here also the severity classification, and on the basis of the classification or the severity grade, the management available to us. So what we know about the VKC is that it is a chronic and bilateral condition. It is presence in children and young adults, and the commonest age of onset is approximately 10 years. Usually resolves after puberty. That reflects that there could be an endocrine influence in the disease pathophysiology. Also, there's a seasonal predilection more commonly during the spring season, where there's a lot of pollens and hot and dry climate is there. So also known as spring catarrh, we know that, and there are episodes of acute exacerbation. So recurrences are the hallmark of this disease. It should also be carefully, differentiated from something which is the atopic keratoconjunctivitis, a similar condition of allergic eye disease. To differentiate it, there is this disease is seen more so in adults. That is, the age of onset is around 20 years, with a strong family history present in most cases. It is also associated with atopic dermatitis, and the lid signs are predominant here. That is, you would see the eczematous lids, the presence of erythema and edema of the lids, the Denny Morgan folds, and because of the constant rubbing, you may see madarosis also. So to differentiate AKC and VKC, as I earlier said, the age of onset is a differentiating feature. The seasonal variation in VKC is seen, however, the AKC is perennial. The discharge type is also a differentiating feature, which is more of thick mucoid ropey discharge in VKC as compared to watery in AKC. The Tranta spots are the differentiating feature, which are not seen in AKC or very rarely. The conjunctival scraping is predominantly eosinophilic in VKC. So, going on to the etiology of VKC, the factors which have been implicated are the immunological mechanism, environmental factors, genetic factors, and a possible endocrine influence. The recent reports indicate that since the disease resolves by puberty, there could be an endocrine influence over the disease process. So the immunological mechanism is mainly by the type 1 hypersensitivity, which is mediated IgE mediated through the mast cells, and interleukins mediated type 4 hypersensitivity. The environmental factors, of course, are important. There is allergens like dust, pollens, mite, or the exposure to pets and exposure to UV lights in these patients, which are important for recurrences seen in these patients. The genetic factors have been implicated because the disease has got an early onset feature. Uh, and to know something more about the immunological cascade, the antigens are mainly, targeted first by the antigen presenting cells. They get activated, and then they are sensitizing the naive T cells. These T cells have got two mechanisms, that is the type 1 and type 4 hypersensitivity. So the type 4 hypersensitivity, that is these T cells then differentiate into the T helper cells, type 2, which release the interleukins, are the inflammatory mediators here, mainly in the type 4 hypersensitivity. Whereas when it sensitizes the B cell, the release of IgE, and these IgE antibodies then further activate the mast cells, which cause the degranulation of the mast cells and release of cytokines and leukotrienes, which are the chemical mediators at the ocular surface, causing various inflammatory processes of the ocular surface in VKC. So we now know that eosinophil is the main culprit here. It is also the dominant cell type seen in the smears of VKC patients, and it is causing the pro-inflammatory and cytotoxic to the corneal epithelium, releasing the toxic enzymes which are causing the epithelial damage in these cases. The clinical examination. So the clinical examination, we first take the symptoms. So the patients commonly complain of ocular itching, the early morning stickiness of the lids, they may be watering and ropey discharge. The corneal involvement, if present, the patient would present with severe photophobia, pain, foreign body sensation, and visual impairment. These patients also, due to constant rubbing and the inflammatory process involved, may develop keratoconus, and the visual impairment would be seen in those cases as well. And important here to note that this is exacerbated on exposure to pollens, on wind, dust, bright light, and hot weather, as I said earlier. What are the types of VKC? So we know VKC by these three types, that is the palpable, which mainly involves the palpable conjunctiva, the bulbar or the bulbar conjunctiva and the limbus is involved, and the mixed variety where both the palpable and the bulbar and limbal involvement would be seen. I would be taking them one by one. First, we see what is palpebral VKC. So, as the name suggests, the palpebral VKC is when the inflammation is present mainly in the palpebral conjunctiva. So, the papillary hyperplasia is the hallmark. We see the papillary hyperplasia in the form of small papillae about zero point 0.5 to 1 millimeter to larger size papillae about 5 millimeter. When there's larger size, the discrete flat top like this, and when they're more extensive, they may develop into cobblestone appearance, and which is also called as the giant papillary conjunctivitis or the GPC. In addition, you would see the Maxwell-Lyon sign, which is because of the coagulation of this thick ropey mucus discharge in due to presence of heat, and this forms a pseudomembrane at the upper tarsal conjunctiva. This is the spectrum of papillary hypertrophy which can be seen. You can see a velvety tarsal conjunctiva here. You can see small papillae here around 1 millimeter, and these are the GPCs or the giant papillary conjunctivitis of around 3 to 5 millimeters seen in such patients in chronic cases. Again, some of the cases which show the severity grade is small papillary hypertrophy to about 0.5 to 1 millimeter size to large size cobblestone appearance. Then the second type is the bulbar or the limbal VKC. The hallmark here is the conjunctival congestion and involvement of the bulbar conjunctiva particularly. You see Horner-Tranter spots which are pathognomic for this, that is the presence of these excrescences or mounds of mucus and epithelial cells and debris at limbus. And in addition, you'll see some limbal hyperplasia also. There's gelatinous confluent limbal papillae. The pseudogerontoxin, as the name suggests, that is, there's a formation of arcocinalis-like appearance in the periphery of the cornea, which is mainly because of the lipid deposition in the superficial corneal stroma. And the process here involved is not the degenerative, but the inflammatory process is implicated. And also in the evolving stage, we may see pigmentation of the interpalpebral conjunctiva. So these are the spectrum of disease in the limbal VKC. You can see these small gelatinous nodules here. We see the Horner-Tranter spots, the limbal hyperplasia, which is again an inflammatory response and formation of pseudogerontoxin. These are the eyes of the same patient, the right OD and the OS of the patients, and you can see the limbal hyperplasia in around 6 clock hours, around 4 clock hours in both the eyes, and also presence of this hyperplastic limbus here with formation of larger nodules at the surface. The formation of pseudogerontoxin, like here you can see the inflammatory, peripheral widening of the cornea at 360 degrees. During the evolving phase, we will see this pigmentation on the conjunctiva that is in the interpalpebral region. Coming on to the third type, that is the mixed type. In the mixed type, you may have inflammation both of the tarsal conjunctiva as well as the bulbar and the limbal, that is the mixed variety. The corneal involvement is seen in moderate to severe and very severe disease. In the mild and moderate intermittent, the corneal involvement would not be seen. But as the disease progresses or the more severe diseases, you'll see the corneal involvement as well. So we see the punctate epithelial erosions because of the inflammatory process. There may be formation of this pannus-like appearance here. And this pannus is again mainly because of the surface inflammation and also the limbal stem cell deficiency, which may be seen in more chronic cases. Presence of shield ulcer, which is again because of mechanical factors of GPC, and also surface inflammation because of the chemical toxins released by the inflammatory process. They may also lead to the coarse epitheliopathy or macroerosions and presence of keratoconus in more severe of the cases. Keratoconus is seen in around 26% of the cases of VKC, and abnormal topography would be seen as high as 70% of the cases. So it is very important that we also evaluate all cases of VKC with the corneal topography to rule out the presence of keratoconus, or if there is an abnormal topography, we need to follow up the patient. The shield ulcer is one of the most dreaded complications and very intractable condition to manage. So it is, as I said, the main the predisposition here is the mechanical abrasion, which is being caused due to the giant papillae and also the cytotoxic mediators released by the eosinophil, the prostaglandins, leukotrienes, and the interleukins mediated inflammation of the ocular surface. They are epitheliotoxic and inhibit wound healing. So once the epithelial defect occurs, because of the delayed wound healing, it takes a chronic form and forms a sort of a ulcer in the central, which is of course a sterile ulcer, and it prevents the epithelial healing from the margins. So the exposed Bowman's membrane here is coated with the gets coated with the mucus and debris, and also later on the calcium phosphate gets deposited, leading to formation of this Shields ulcer and delayed reepithelialization. So grading of Cameroon, this grading of Shields ulcer by this Cameroon grading system is important and very often asked in your exam. So we grade it in the grading severity of 1, 2, and 3. Ulcer with a transparent base, ulcer with a translucent base, that is the inflammatory deposit over the base of the ulcer, and ulcer with an elevated plaque, just like seen here. The treatment varies. In grade 1, which is the ulcer with a transparent base, the topical treatment with steroids and mast cell stabilizer and a frequent lubrication of the ocular surface, supplemented with a BCL, heals the ulcer in most of the times. Ulcer with the translucent base, you would need to remove this debris which is present here so that the epithelial healing takes over. And for that, the scraping followed by this topical treatment and application of BCL would be required. This ulcer with elevated plaque, again, you would need to remove this the debris, that is the mucus plaque, from the surface with a careful debridement. We need to refresh the edges of this, the margins of these ulcer, and after removal of the plaque, we need to do an amniotic membrane transplantation supplemented with the adequate topical treatment for relieving of this grade 3 ulcer. And this may also require repeat process because, as I said earlier, the disease may be intractable to treat. And also we need to manage the GPC in such cases, otherwise it will recur or there would be problems in healing. So after knowing the types of the corneal, types of the VKC and the Shields ulcer, we go up to how do we do a workup of a case of VKC. So mainly we, as just like other clinical cases, we take first the history and next is the clinical examination. So here the history is very important. You must know the onset, the duration, various predispositions, relieving factors, and seasonal predilection in these cases to differentiate it VKC from AKC, and also the history of prior treatment, whether the patient got relief from the treatment applied, and the duration of treatment, and whether there was relief is important because that gives you an idea whether the patient was on steroid, did he take any other treatment, what was the duration of the steroid or any other topical treatment taken. So that will also drive your treatment which you would want to prescribe. The personal family history of atopy, asthma, rhinitis is very important because during the course of treatment, you would also like to address these systemic conditions so that there's an optimum management of the local as well. History of discharge, pain, photophobia, visual symptoms, lymphadenopathy, again is important to give you an idea of any superimposed secondary infection in these cases or whether there's any corneal involvement. Going to the clinical examination, you have to assess the patient both on severity as well as periodicity. So the severity is assessed on from mild to very severe, that is mild, moderate, severe, and very severe or the blinding. Periodicity is assessed in terms of whether the disease is intermittent or chronic. Intermittent disease is one where the disease-free interval without medication is around 3 months. So there is a disease-free interval in such patients of at least 2 to 3 months, and in which duration the patient is without any treatment. And the maximum such episodes would be around not more than 3 episodes in a year. Whereas a chronic disease, the disease-free interval is just around a month and without treatment. And once you stop the treatment, the disease recurs. So that is how we differentiate an intermittent disease from a chronic disease. And on the basis of this, that is both the severity and the intermittence or the chronicity of the disease, this grading system has been given. That is the Bonini's grading. You can see these the clinical parameters, that is on the basis of symptoms and conjunctival involvement, presence of limbal involvement, and corneal involvement, and then the grades have been defined. So it is grade 1, 2, 3, and 4. So grade 1 is mild disease, grade 2 is moderate, grade 3 severe, and grade 4 is very severe disease. Grade 2 is again subclassified into moderate intermittent and moderate persistent. So mild disease, as it says, that it is mild conjunctival inflammation may be present without any corneal involvement. In moderate intermittent also, the corneal involvement would not be seen. But in moderate persistent, there may be presence of papillary hypertrophy to moderate severity, and in addition, patient may show some SPs. In severe involvement, of course, the disease process, the inflammation is severe, so you would see the severe conjunctival inflammation, formation of large size papillae, and corneal involvement. In very severe, you'll see formation of Shields ulcer in addition to formation of GPCs and severe conjunctival inflammation. So these are some of the pictures of the disease severity, as I said in the previous slide. So mild intermittent. In the moderate intermittent, you will see some inflammation of conjunctiva and bulbar, but the no corneal involvement will be seen. In moderate persistent, there you may see some SPEs and the papillary hypertrophy. In severe disease, you would see the coarse erosions as well as severe inflammation of the conjunctiva, both palpebral and the limbal, and also presence of coarse erosions. In the very severe, the Shields ulcer would be seen in addition to the severe inflammation, as I said earlier, like involving the palpebral conjunctiva. How do you investigate a case of BKC? It is mostly a clinical diagnosis. So we see the patient with a careful clinical examination of the clinical features, the disease severity, and the chronicity of the disease. We can make the diagnosis of the patient as a case of BKC. It should always be supplemented with corneal topography, as I earlier said, and ASOCT to know about whether there's inflammatory process which is also involving the cornea. In addition, you may subject the patient for any systemic allergic disease with the help of either a complete blood picture, the chest x-rays, immunological test, serum and serum tear levels of IgE, and skin patch test sometimes to rule out any other systemic allergies, which is important because then you would want to refer such patients for pediatric checkup and pediatric management also for systemic conditions. Coming on to management now. So the management, as I earlier said, depends on the severity grading, and not all patients would require steroids. The treatment largely depends on the disease severity. So it involves not only the management through the systemic and the local drugs, it also involves the management of the environmental factors, which is very important to control BKC. Otherwise, all our efforts of treatment would go in vain should we not control the environmental or the inflammatory or the allergic allergens which the patient is exposed to. So what do we have in store? The pharmacological agents which we have can be classified into antihistamines, mast cell stabilizers, the dual acting agents which have got properties both of antihistamines and the mast cells, and the NSAIDs, that is mainly used as the ketorolac, corticosteroids, and lubricants. So the antihistamines can be both topical and systemic. The systemic drugs are loratadine, ceprozine, which can be given to patients for acute relief of symptoms. They can be given for a week's time and continued for another week if required. Topical antihistamines like amidestine or levobastine can be given. Mast cell stabilizers, mainly the sodium chromoglycate, nedocromil, or lodoxamide, are available in these concentrations. The dual action, which have got the actions of both, that is ezelastine, ketotifen, olopatadine, are the other drugs available. NSAIDs, the ketorolac, are given for patients as steroid-sparing agent, but it should be carefully looked that the patient does not have any corneal involvement when you're prescribing a ketorolac eye drop. Corticosteroid, both the soft steroids like loteprednol and fluorometholone can be given in addition to prednisolone and dexamethasone in these concentrations. Immunomodulators, mainly comprising of the topical cyclosporin and topical tacrolimus in concentration of 0.03%. They can also be given as systemic drugs also in very severe blinding disease, which we'll see later. So going on to the specific cases as per the disease classification, for the mild disease, you mainly need the environmental factors control, that is avoidance of allergens, and supplement it with lubricants, topical antihistamines, and mast cell stabilizers. You can give ketorolac also, but be careful that the cornea is not involved in such cases. So that is called as ALHM management of mild cases. So the ALHM we would see in the subsequent severity grades also, that is from moderate to severe, but of course it has to be supplemented with other specific treatments. So let us see how do we treat a moderate disease. So moderate disease, in addition to the ALHM, that is the avoidance of allergens, lubricants, antihistamines, and the mast cell stabilizers in the early course of the disease, you may want to give short pulse of soft steroids. So the short pulse we mean by around steroid dosing in tapering dose for around 2 to 3 weeks. And if the disease does not respond to that, you may move to topical cyclosporin in moderate persistent disease, or tacrolimus transdermally can be given. That, of course, it depends on the severity, the response to treatment on the basis of chronicity. The severe disease, we want to give short pulse of potent steroids, because the others, the soft steroids would not be able to control this extensive inflammation. So you want to give dexamethasone or prednisolone, again in tapering dose, and short pulses for around 2 to 3 weeks. You can give later on, replace it with the cyclosporin or tacrolimus 0.03% transdermally for a longer period of time. For blinding disease or very severe disease, in addition to all these, you may require surgical management of such cases, because these patients, as I said earlier, are very intractable to treat. The ongoing inflammation may result into a blinding, involvement of the cornea, and hence we may require a surgical management of either a supratarsal depot injection, debridement of Shields ulcer, or any other surgical procedure, which I would be taking in subsequent slides. The systemic therapy comprises of oral cyclosporin, 3 milligram per kg body weight, in coordination with the pediatrician, should be started in very severe blinding diseases. Other options are intravenous immunoglobulins and the biologicals like the omalizumab, that is a monoclonal anti-Ig antibody, which can be given every 2 weeks, can be supplemented every 2 weeks in subconjunctival dosing of around 500 to 600 milligram. Coming on to the surgical therapy, the surgical therapy comprises of the listing comprises of the supratarsal injection, AMTs, that is the debridement and amniotic membrane transplantation, shave excision of these giant papillary areas, debridement and superficial keratectomies, application of BCL, and keratectomy for blinding corneal opacities. So how do we give a supratarsal injection in such cases? You should rule out whether the patient is a case of steroid responder, and should be judiciously given in very severe cases, because when you give a depot preparation of either triamcinolone or dexamethasone, patient may have rise of IOP. So it should be given carefully and after complete clinical assessment of the patient. So what is the drug which is used here is the triamcinolone in 0.5 ml, that is 20 milligram, and similarly Dexa 2 milligram can be given. It is given 27 with a 27 gauge needle. The site where you want to give this, it is around 1 millimeter above the supratarsal border. It should be given, the care should be taken that it is not given in the subconjunctival state, rather than on the supratarsal space, and there should be the ballooning of this space over the supratarsal area. And after application of the subconjunctival injection, you should patch the eye with antibiotics and lubricants in these cases. So that was the supratarsal injection and the technique of giving the supratarsal injection. How do we do the debridement with AMT and application of amniotic membrane transplantation? So careful debridement of this Shields ulcer or a corneal involvement is being done with a simple hockey stick, and you see that we are debriding the mucus from the base of the ulcer and the debris, and freshening up the edges of the ulcer, followed by careful debridement and cleaning, and then we apply the amniotic membrane with a careful orientation of the surface. We fix it with either the fibrin glue and application of some sutures here, because in pediatric patients, the sutures are important, otherwise they may get dislodged by the patient sometimes rubbing the eyes. So careful application of the amniotic membrane with an orientation which is epithelial with the stromal side down. So here we are applying sutures here so that the amniotic membrane is fixed into place, because in children there's a chance or possibility of dislodgement of the amniotic membrane in the post-operative period. So it is a good practice to apply some sutures here to fix it in place. Again, a case of Shields ulcer, which was debrided and formation with the application of the amniotic membrane. Now, shave excision with MMG is a technique where the GPCs are causing corneal abrasion and non-healing, Shields ulcer, with the constant mechanical damage is there in addition to inflammatory processes. So in that case, you shave off these giant papillary hypertrophic areas and supplement it with the buccal mucosa harvested mucous membrane. But sometimes the underlying inflammatory process may go on, or it is continuing. So we may never know that what is happening underneath the membrane. So very judicious decision to remove the shave of the papillary hypertrophy, and application of the membrane should be taken, and a strict control of inflammation, of ocular surface inflammation, should be ensured, and preferably should be done in cases where we are sure that there has been a quiescent plaque at least for 6 months before applying of this MMG. So the harvesting of the MMG is done from the buccal mucosa, and a very thin strip of a mucous membrane is sutured on to the lid margin, and covering the area which has been debrided. And the application, that what we are doing is we are getting rid of the papillary hypertrophy and getting a smooth surface over that area so that the further mechanical damage does not take place. In blinding disease, like formation of a corneal opacity, you would not have any other option but to do a PK. So this case was a case of secondary glaucoma as well. So we did a crab along with a PK and a careful dissection of the corneal opacity, followed by the adequately sized graft is there. But again, the post-operative control of inflammation is very, very important in this case. Otherwise, there may be chances of, primary graft failure or rejection later on, and an ongoing inflammatory process is there. So careful dissection of the case, and careful dissection of the involved area, and followed by the grafting of the tissue. This was the case which we did for PK. The patient is doing well after control of inflammation. The patient, the timing of the treatment for this patient was 17 years. Till that time, we controlled the inflammation with the topical drugs. So a step ladder approach is what we require in a case of BKC. For mild allergies or mild cases, you require just the ALHM and mast cell stabilizers, antihistamines. For moderate disease, particularly the moderate persistent, you would require short pulses of steroids, and maybe you can replace it with cyclosporins and tacrolimus transdermally. For vision threatening or for very severe disease, you may require systemic immunosuppression in addition to surgical management of Shields ulcer. And not to forget that you have to have the primary cause to be eliminated, that is the allergens which are causing the disease, avoidance of allergens, dust, mites, pollens, and also the cold compresses to get relief to the patients, in addition to lubricants and cycloplegics are important. And very important is the education of patients and their parents that the disease has got a recurring course, and what we could best do is control of inflammation and increase the duration of remission between two episodes. So the patient, when counseled, knows that the disease would have a recurring phase, and how he has to manage the disease by himself as well, in coordination with the treating ophthalmologist. After the treatment, the complications, I think we have covered almost while discussing the clinical features as well. So there can be steroid-induced cataract and glaucoma, which has to be managed. The keratoconus, as I said earlier, is seen in around 26% of the cases. Presence of SPEs, again, can be controlled with lubricants and local control of anti-inflammatory agents. There can be LSCDs, there can be secondary infections and dry eye disease, which has to be appropriately managed as per the requirement or the clinical condition. So the carry home message today would be that you should be able to differentiate between BKC and AKC. There should be careful evaluation of clinical features. because on the basis of the clinical features would we be able to to grade the disease severity. The counseling is very important on the chronicity of the disease and the recurring nature of the disease. The stepwise management should be there. Not all cases should be given steroids, and the stepwise management based on the severity is stressed upon. And for steroids, we have to exercise restraints because not all cases, as I said earlier, would require steroids. So after taking this lecture, I hope that now it is indeed a child's game for you. This was the child who's recently being seen in very viral videos, who's a grandmaster of chess, and so I hope that the this class of viral keratitis of VKC is has resolved all your doubts about the clinical features, diagnosis, and management. Thank you very much.
Thank you, Dr. Bhavna, for that very complete and thorough overview of VKC. And you very aptly highlighted the high incidence of keratoconus in these children that we should, look out for. And you showed some amazing surgical videos regarding the management of complications of VKC. So congratulations, that was a very nice lecture. With that, we move on to our expert panel for their comments and their anything that they'd like to add to this. So I first invite Dr. Bhaskar Srinivasan for his comments.
Yeah, thanks, Tinku. A very well explained chapter, Dr. Bhavna. Just a couple of points for the postgraduates. One is for any disease, you will need to remember the classifications and gradings because that helps you manage these patients better. So whether it is the grading of papillae, whether it is grading of the shield ulcer, not just from the exam point of view, but also from a treatment point of view. Because if you look at the Bonini's classification and also you look at Nikhil Gokhale's classification that he's put up in IJO, it actually helps you in deciding on your line of management in terms of what is the time that you would start steroids. So that part, Nikhil's classification, I think you will probably get it in IGO and you'll have to probably go back and check that. That was one. Second, keratoconus is to be looked at, but the topography timing is important. If you have a lot of corneal SPKs and irregularity in the cornea, your topography is not going to be regular. So you would want to repeat the topography once the active inflammation comes under control. Three, the most important part as far as VKC is concerned is to avoid going to the stage where we end up with complications, which means the moment the disease starts affecting the cornea, your threshold for intervention and a threshold for medical management, whether it is topical steroids, whether it is topical immunomodulators like topical tacrolimus and topical cyclosporine, whether it is systemic immunomodulators, or it is surgical intervention in terms of taking care of the papillae with either a tricot injection into the papillae. So the moment your corneal problems start happening more, and if it starts recurring the moment you stop the topical steroids, you will have to step the ladder up to the next level of treatment as such. And as far as the complications are concerned, yes, keratoconus, if it happens, you will need to control the allergy, and if it is a progressing, because in a pediatric age group, unless you control the allergy, the keratoconus is also going to progress. So you will have to control the disease, and if you have to plan a cross linkage, you will have to plan it once the eye is absolutely quiet.
Thank you. Thank you. Dr. Jayesh, anything that you'd like to add to this?
Yes, I think Professor Sharma has pretty much covered everything very comprehensively. I would just encourage the postgraduate students to read about the recent literature. Now there's a lot of literature on the use of topical tacrolimus in VKC, and the safety is well established. And that gives us a very good option to keep the patient off steroids. So Professor Sharma did mention it, but there's a lot of literature now which the students should read. Likewise, now there is an increasing body of literature on the use of systemic immunomodulatory therapy. Cyclosporin, Professor Sharma mentioned. Now people are also using, I myself also using, there are others have mentioned the use of systemic tacrolimus also in very low doses. So this is for very extreme cases and severe and blinding disease only. But so that is two. And the third thing which they might want to read about and mention in their exams is the growing body of literature which shows the incidence of each specific complication of VKC. So ocular surface complications such as limbal stem cell deficiency, incidence of keratoconus has been mentioned, steroid-induced glaucoma and cataract. So overall, a very comprehensive talk. So very little to add.
Dr. Vazirani, how often you just mentioned you use immunomodulatory therapy? How often and which cases are the ones
Yes.
that you would go for?
So it depends on what kind of practice setting you are in. So for someone who is a comprehensive ophthalmologist or mainly sees mild or moderate intermittent VKC, it will not be required. But I mainly get cases which have been uh, uh, on and off on steroids. Sometimes most of them are steroid responders. Sometimes they have glaucoma, and these are chronic, severe, or blinding disease. So when you have a patient who has very severe inflammation and it is not controlled and you have secondary complications and the patient is a steroid responder, you're left with very little options. So those are the cases which do very well on systemic cyclosporin or tacrolimus.
And this is what, it's a subcutaneous, or is it how
No,
is it?
systemic, it's a tablet.
That's a tab.
It's a tablet.
Okay. And what about the other immunomodulatory like omalizumab that has just come in? Do you also use that?
Omalizumab has to be given very frequently and it is expensive. And I have no personal experience with it, mainly due to the costs. But the literature I have gone through says that the effect is transient because it hits the disease at a lower level in the inflammatory cascade. So it deals with Ig and not the T cells. Whereas if you use something like cyclosporin or tacrolimus, you control pretty much the entire inflammatory cascade right at the base, that is the cell, the T cells. So no personal experience with omalizumab. I have experience with methotrexate and in a couple of patients with mycophenolate. So all of them would fall into immunomodulatory drugs.
Thank you so much.
Yeah.
I now invite Dr. Vanati for her comments and inputs.
Thank you, Tinku. And I think it's a very comprehensive talk by Dr. Bhavna there. A few points, I think, already elaborated by both Bhaskar and Jayesh here. We do see a lot of VKC which is still managed in general ophthalmology practice here. And that is what the general ophthalmologists need to look at and really need to identify the secondary complications of VKC is perhaps much higher than the blinding complications here. So secondary glaucoma in these patients here is a steroid-induced glaucoma because of over-treating the disease with steroid or not monitoring the intraocular pressure or the steroid response of every particular eye to the steroid being used is something which every general practitioner needs to be aware of when they are managing. Of course, the moment, as rightly pointed out, it's starting on giving corneal complications and the steroid dependency factor is increasing, then you would have to move into your next step of management. And I think there's a lot of literature now which talks about using tacrolimus eye ointment 0.1% over the eyelids because tacrolimus in the topical applications is quite toxic and many of these children, pediatric cases, do not tolerate them and land stopping these medicines. So tacrolimus ointment applications over the lids works really well in pediatric cases and really helps to control the palpable diseases very successfully given over a period of about 3 months here. So that's another take-home point which would be useful for all the general practitioners who are managing VKC and AKC patients.
Thank you, Dr. Vanati. That was an excellent pointer. Yeah, please carry on.
One point can I make, Tinku? I think counseling of the parents is extremely important in VKC. We see many parents who come to us, 2 weeks, they would have gone to one practitioner, things respond. Then again, when you stop the medicines, everything comes back. Then they go to a second practitioner. By the time they come to you, they have what we call a thela full of medicines, a full basket full. So they need to be counseled that it's an ongoing process. It's going to be there till the child is 20, 25, unless, of course, it's an adult onset VKC. So I think the main important thing is counseling. All the medication, everything apart, the parents need to be counseled. They are the ones who are going to blind their child in the long run.
Thank you. Dr. Pillai, anything that... Dr. Pillai? He's not. Yeah, Dr. Bhaskar, you were saying something.
So the important thing is in counseling, when we start a steroid for any patient with VKC, tell the parents that this drop can cause blindness. It's to be given under only supervision, because what happens is they see you giving, say, a dexamethasone or a loteprednisolone, so it's very tempting for them the next instance to just give the drop by themselves. So you caution the parent right at the first visit that this will work, but this has to be given only under our supervision, because this can cause a blinding disease. So once you instill the fear, at least the possibility of them overusing or misusing the drop is much lesser.
Dr. Vanati, what would be your choice in a mild to moderate case? What would be your choice of, the regimen that you start with in these cases?
Hello, yeah.
Yeah.
I think
In a mild to moderate case, what would be your treatment regimen that you start with?
see again, when we start steroids, it also depends upon whether these are the primary case which you are looking at, or you're looking at a case which exacerbations here, or you're looking at a case which is having symptoms throughout the year here. Okay, so when you're looking at a mild to moderate, you would always start with a lower potency steroid here. And again, the exacerbations could be in a case where they have been having corneal problems, but the corneal problems are settled and it's only a lid disease which you are seeing. So there's a mix and match about the severity of the cases, and I'll probably start with the low potency steroid for these patients here. Watch their steroid response to the medication which is being given. So looking at the fundus for these patients as a baseline record, and also monitoring pressures on follow-up visits, it's very important in these patients as well. And of course, a 3-monthly look at their axial lens, and also to look at their curvature myopias. So these are also features because they are always in the pediatric age groups, and you might see a lot of patients who are compound myopic astigmatisms with thin corneas and need not necessarily be keratoconus patients here. So the urge to overtreat, the urge to, overdiagnose, and also be cautious about underdiagnosing steroid-induced glaucoma, of underdiagnosing the steroid effects needs to be kept, Renee. And the moment you feel that the steroid potency in a mild case is not controlling the disease, and it goes sort of moves to a moderate disease there, then you will have to think about shifting your steroids.
Thank you. So with that, we move on. Thank you all for your excellent inputs. I think we've had a very great interactive discussion. So with that, we move on to our next speaker. I'll just share my screen. So our next speaker is Dr. Abhishek Onkar, who's an associate professor and head of the Department of Ophthalmology at the All India Institute of Medical Sciences at Deoghar. With over 10 years of academic experience, his areas of interest include community ophthalmology and glaucoma. He's been a recipient of several awards, including the AIOS ARC PN Sinha Award in 2014, the APSOPRS Travel Grant, the World Ophthalmology Congress 2020 Travel Grant, and the Jharkhand Ophthalmic Society Excellent Award in 23. So welcome, Dr. Abhishek, and I invite you to speak on your chosen topic of computer vision syndrome. So this is something that is of relevance not only to the PGs, but to all practicing ophthalmologists, and really looking forward to your talk.
Thank you, ma'am. Respected seniors, panelists, experts, and fraternity. Good morning to you all. I thank AIOS for this opportunity for presenting my talk in this coveted GuruSangam conclave. I'll just be sharing my screen, and then we'll. So, are my slides visible?
Not as yet, no.
Is it visible now?
Yeah, it's visible, but it's not full screen.
Yeah. Is it okay now?
Yes, it's fine.
So, coming to the topic now, like when we talk about ocular surface, that is this session, mainly it is being what forms the backbone for PG teaching has been the inflammations and the tumors when we talk about ocular surface. Computer vision syndrome remains taken for granted and has not been given that much of importance. It is like taken for granted, and but Yes. So while I cover this talk, and by the end of this session, I hope that I would be able to justify my talk by the whys and wherefores of this computer vision syndrome, the topic of relevance for the postgraduate. So before starting to the main slides, there are two sessions that we held actually with our interns and two PGs actually. So we'll just go through it and have a look at what happens. So let's move on to the other video.
Doctor, there's no voice.
Does this video have audio in it? Because we can't hear.
Just a second.
Dr. Abhishek, is there any audio in the video?
There is a audio.
No,
but,
audio is not coming. Can you just stop for a minute?
Just a second.
Can you unshare, stop share actually? Just click on the share button once. You will have a share sound option. Just tick that box, please, before sharing.
Yeah. Okay, thanks.
Now you can replay the video so that the voice is there from the start. If you can play from the start, Doctor. We are not able to hear.
Orange shirts.
Yes, thank you.
Thank you.
Here's your challenge. How many people in orange shirts get subs? Go. Seven people in orange shirts got subs. But what else did you see? Did you notice the ice cream truck change to a pizza truck?
So I will stop the videos as for now. So there were two phenomena happening in those two videos, which we'll discuss further, which are particularly relevant to computer vision syndrome. So coming to the topic in itself, so it is an umbrella term for complicated eye and vision difficulties that are linked to stress that the eyes have for near work. And one specified classification has been given by TFS, the Tear Film and Ocular Surface Society lifestyle reports, which define computer vision syndrome, or what we call it as digital eye strain nowadays, as the exacerbation of recurrent ocular symptoms or signs related to device viewing, and mainly the screen viewing. So historically, this digitalized strain has been termed as computer vision syndrome, but now we can, it is more of a misnomer since smartphones have replaced computer screens for most of the tasks. Now, the relevance and the impact of this problem is that one of the studies, two systemic reviews, which comprise of 743 and 103 respectively studies, which were incorporated with more than like 66,000 participants in those two systematic reviews, which were recently published in 2023 and 24, one in Nature Journal. One of them is a Nature Journal publication. So they estimated the prevalence of computer vision syndrome to be around 66% to 69%, ranging from 12 to 97.3% across the studies, with like country-specific data being like more prevalent in Pakistan and Asia and Africa, and very low in actually Japan. So that was the least that they observed. Very high in university students, that makes it like a very pertinent thing when we are talking about postgraduate students, because they can correlate to this entity. And since these are like job related viewing demands, and nowadays, especially post COVID, screen has been the mainstay of teaching and learning for undergraduates or postgraduates. So this equalizes to visual fatigue, the digitalized strain. And so more they spend the time on screens, like recommended is like if it is more than 3 hours per day, definitely some form of computer vision syndrome symptoms will be there in that subject. So the obvious aspects that we know of regarding computer vision syndrome are the extraocular ones related to the posturing, the musculoskeletal part, shoulder pain, neck pain, headache, and backache. The visual symptoms, blood vision specifically. Now, this is something that we come across when undergraduates come to us like 2 or 3 days before exam, or when they have a crunch PPT to make. Next day, they would be in the ophthalmology OPD, telling them that when we are looking at the screen, it is fine, but suddenly when we look at the clock far away or something distance, it gets blurred. And even they come up with severe headaches. And I think I can recount at least two of my undergraduates having like a raised IOP kind of incidents also, which subsided once he was given a proper break from the screens. So, like the blood vision, double vision, and slowness of focus. So, the ocular symptoms, eye strain, asthenopic symptoms, and tearing and irritation definitely form a part of it. So, the oblivious part, which we do not actually look into when we talk about computer vision syndrome, are the disturbance of the sleep and circadian rhythm. Now, there's been a lot of talk about regarding the blue filters being used. Now, directly, they do not affect, they're not affect the part of computer vision symptoms uh, gamut. But yes, indirectly, they definitely have an effect because the blue lights interfere with the melatonin cycle, and they disturb the sleep circadian rhythm, and definitely that hampers your sleep and the tear components as well. And the neuropsychiatric issues have also been reported in a few of the studies as quoted, and they have shown to be epileptogenic as well. And definitely the job burnout and stress has been documented with loss of work hours globally. Now, when we translate it in terms of our postgraduates, that can result in like poor surgical outcomes even. Now, that has not been documented, but definitely we can come up with some studies regarding that. So when we come to the pediatric population, I think one of the major key aspects is the myopia. So there's been a lot of publications regarding myopia post-COVID coming up because of the screen usage. And so much has been the impetus that now we have such slogans like more of greens, less of screens, National Myopia Weeks being organized regularly, and even a National Myopia conclave was held in AIIMS New Delhi RP Center for formulating guidelines for this myopia elimination, and one of the mainstays remains the off-screen. So recommended guidelines with WHO is like less than 1 hour or less than half hour if for a less aged child. And all those symptoms what have been mentioned here, obesity, altered sleep time, irritability, attention span, they are all related to screen time more or less. And it has also been documented by Moon et al. That just by cessation of smartphone users for a 4-week period actually leads to improvement in all those symptoms as well. So it has been a leading occupational hazard of the century, with more than 60 million people suffering, as we already mentioned. So almost 7 out of 10 or 2 out of 3 people suffer from computer vision syndrome, as has been documented by those 2 systematic reviews. And those who are on computer uses regularly with for more than 2 or 3 hours, 60% will be having some or the other symptom of it. And it may increase task errors, so almost 3.5 times. So it has been equated as an epidemic of digital era. And so that was the task related things and the data regarding the magnanimity of this entity. Now when we come to the research part, so if you just type in computer vision syndrome in the PubMed and go for the search, if you can just find that the most it is like has been upsurge after COVID-19, and most of the publications come out in the past 4 or 5 years only. So this provides very fertile grounds for research for our postgraduates as well. So addressing the why computer vision syndrome is to be catered to is because of the individual visual impediments that can cause it. Insufficient blinking, that is something that is related to the first video that we saw. If you could have monitored it, we can replay it again maybe. So the intern was actually hardly blinked. He blinked only 2 or 3 times during that 1 minute period. The poor workstation ergonomics, that is one thing that we'll be talking about, and the evolutionary changes which actually act as impediment for our customization to the screens. So demand versus the capacity ratio. So talking about the individual impediments that can lead to computer vision syndrome or accentuate are one is uncorrected astigmatism or even uncorrected refractive errors, myopia and presbyopia. One thing is like when we talk about presbyopic patients, they have a more increased demand for correction. So they have to be corrected well, and rather than going for progressive glasses, occupational glasses come to be more handy as has been documented. Reduced blink rate and incomplete blink. These are 2 things that are frequently encountered, as has been documented in the first 2 videos that we saw. In the first one, it was like 2-3 blinks, as opposed to like 15 or 16 blinks that we should be having per minute. While in the second video, if you could have observed the person, when the video was not playing, there was only text, he was blinking quite frequently, and by the end of 1 minute he actually blinked 15 or 16 times, but the quality of blink was not adequate. It was like flutters rather than blinks. It was in sputters. Whenever he tried to capture, okay, how many in orange we are capturing those subs, it was like he was blinking very frequently, so almost 3 to 4 blinks in 1 second. So the quality of blink and the number of blinks, they both matter, which lead to the equal dispersion of the tear film and for proper lubrication of the ocular surface, which if not catered to will definitely precipitate the evaporative dry eye symptoms and aggravate it. So yeah, so the blink rates have been documented, as was seen in this video also. If someone is performing a focused task, it reduces to less than 4 to 8 blinks per minute. And of course, with near being, the strain on ciliary muscles accentuate the stenopic symptoms and the blurring part. And yes, now talking about the workplace ergonomics. So the viewing angle, how you posture your laptops, the smartphones, and your angle with the screen, brightness of the screen, the room illumination, they all matter. And they all have a huge impact on how your suitability to the screen is and how you can avoid the symptoms of computer vision syndrome. So what has been, now this is like something will say that I just tried to focus in with those glossy screens with a overhead table lamp. So this is like very difficult to read and it's a lot of strain. So not only the screen, but even a print can cause such a thing. You can just have a difference between these two pages, how well illuminated and how it is easy on the eyes. That is one thing that we can talk about. And it has also been like documented by Argyles et al. In 2015 that incomplete things are more when we are looking at the screens and such glossy papers rather than easy on to read with a good illumination. Fewer pixels definitely make it difficult. High brightness and high contrast make it difficult. So they have to be reduced and it has to be accustomed for like customized for each one at which they are comfortable reading. But as a norm, it should be like less than 50%, or you can just whatever you're using and you're uncomfortable with it, increase it by 20%. That is something that gives you relief and gradually you can get accustomed to it. All caps are a strict no. That is what rule of the book says when we are making the presentations also. So I think I'm not sticking to it in many of my slides. All caps and the 555 rule, the spacing between the characters and the background. So those things have to be taken into account. Now, this is something that has been shown very well. So when the viewing angle, so if the screen is like higher up than your eye level, so that exposes more of the ocular surface and that leads to more of the evaporation that has been postulated, and that can aggravate dry eye symptoms related to screen viewing. So proper screen viewing at the same level or a bit lower can decrease the exposure of the ocular surface and help you get relief, provide some relief from the symptoms. Critical flicker frequency has been also studied a lot in terms of computer vision. So it is the refresh rate at which the human visual system fails to recognize the flickering nature of the screen, and it starts appearing as a normal without any flicker to it. So normal value is 30 to 50. Low refresh rates can cause fatigue. So that is something that has to be taken into account when we are adjusting to our screens. Blue light, as I already documented, so it's not directly related to the computer vision syndrome, but yes, indirectly it definitely plays a role in aggravating those symptoms of dry eye and computer vision syndrome. So the demand versus the adaptation capacity is limited for us. That is, if we look at the demand, so the number of smartphones globally and in India has increased tremendously. With I think this is like the diabetic hub that we have become. It's going to be a smartphone hub, if not already. So the demand has already been there over us. The time spent has increased almost 4 to 5 times with the gadgets. That is something, but our eyes have a limited capacity to it. So opening the eyes versus, so anatomically, we have a limited capacity to adapt to this increased demand. So if we are not adapting to it, we definitely have to resort to some measures which are not actually very advisable. So that is one thing, that demand anatomically is not being met, but we are still exerting our eyes to do that task. Physiologically also, it is not what we can get accustomed we are doing, but definitely it is not as per what should have been done. So reduced depth of focus, increase in pupil size, and constriction after completion of the demanding tasks. So these all create a lot of demand on our accommodation system and leads to those symptoms of fatigue and asthenopia and blurring. Pixels we already talked about. Solid lines on pages are easy to read, while the pixels, if they are heavily pixelated, are lead to a lot of strain on the eyes. Evolutionary, so anatomically, physiologically, and when we talk about evolutionary, so from praise to predators. So the eyes are moved towards the center, if we can see, and humans, I think we have to decide whether we are the prey or predators, and if we continue on that trajectory, so I think isotropia is the only way that we are going to look in future. So even if we look at the evolutionary literary content of our evolution, so from hunter-gatherers to using papyrus, it took 9,000 years. From papyrus, it took another 5,000 years. computers have been in use only for 50 years. So like 10,000 years to 50 years, that is what we are straining our eyes to do. So there's definitely adaptation crisis, and we cannot just exert our eyes to so much of work for adaptation. So we are actually doing it, but that has to take a toll. So that is why computer vision syndrome comes into play and has to remain a focus because of that amount of like more than 60% having those symptoms and with adaptation crisis already in place. So translating all these whys in terms of students, so the magnanimity has already been explained with like more than 7 out of 10 people suffering from it. Work productivity, especially in the terms of the surgical focus that may be required when the PGs or the students are like on the screens late night up, and the next day they are in the OT. That focus is definitely going to be hampered. This is something that we can actually come up with a study with. For students itself, it's a fertile ground for research, not only for postgraduates, but even for undergraduate. So for undergraduate, it becomes a very easy because as we will come to the screening part, it is mainly a questionnaire-based studies. And ICMR is short-term student so there's and provides an ample opportunity to work up dry eye diagnostic protocols for the students as you get a lot of patients. As I said, like these are the patients that the generation alpha are going to be tackling most of the time. They themselves being the sufferers for this. So they will be able to correlate and will be able to pick up those diagnoses very easily. And they will be able to perform those diagnostic tests for dry eye with a lot of convenience and at ease. And it's a genuine global problem that has beginning for solution, that there's no doubt about it. So having said that, coming to the management part, mainly it's the screening and the prevention that we can talk about rather than treatment catering to it. So the computer vision syndrome questionnaire remains the backbone, which with more than 75% sensitivity and specificity, and it has been used vastly in almost all the computer vision syndrome studies. The other ones are the National Eye Institute Visual Function Questionnaire and the Ocular Surface Disease Index and the Computer Vision Symptom Scale. Among these computer vision syndrome questionnaire and ocular surface disease index, I find very relevant to use because they also provide a grading for mild, moderate, and severe dryness scale. And they are like very easy to be administered to the patients also. They can be sent online or physically also. So they provide a good scoring, and the patient can actually self-monitor just on the basis of that questionnaire, where are they once the treatment has been started or once they have been weaned off the screens. And there have been like modified versions by the same author, Segoi et al., for the CVS questionnaire for now coming up for the adolescents, and also a smart questionnaire, which is which is a shortened version of the same CVS questionnaire. So this is what the CVS questionnaire is, with all those 16 points, which detail about the symptoms that the patient has. And the OSDI questionnaire, as I said, it becomes easy for the patient to explain it also to the patients where they lie in that zone, mild, moderate, severe, and they can self-monitor it as. CVS Smart Score is something that again helps. This has come out recently. Now, so screening are mainly questionnaire based. Now, this is like something like a herpes zoster thing, which is a walk-in diagnosis for postgraduates as well. So once you see teenager or a early 30s or a 40s patient walking into your eyes with specs, or you know that is a techie person, so you know, and with a screen time already evident more than 4 to 5 hours a day, you can start suspecting about computer vision syndrome or the digital eye strain. So usage of digital device, strong history should not be overlooked whenever we are working up for dry eyes. Infrequent near work breaks, so continued, if they are having a continued presence before the screen, low digital screen brightness. The female gender has been attributed in many of the studies, but there has been conflicting evidence from a few studies. Even one study actually favoring that it has been a male gender that is more exposed to it. Age is mainly again the teenagers and the early 30s and 40s. They are mainly affected, and they have been mostly studied in all the prevalent studies that have come up. Decreased viewing distance less than 20 centimeter, already dry eye disease, and depression and anxiety. So they have been correlated with computer vision syndrome, and they definitely impact the quality of life. Contact lens usage again has been like to and fro. Some studies have hypothesized it to be a risk factor, but many have refuted it as a cause for it. So having screened and having known the risk factors, so prevention is like mainly you have to discuss it with the patient, like how they can wean themselves off the screen, along with changing the ergonomics and the screen brightness, alignment, and those things that can be changed. So that is the major factor that is in their hands, and that has to be discussed and counseled very regularly and very emphatically. Now, glasses and filters, as we said, blue blocking filters are like not directly related to prevention, and they have been off the list. But yes, coming as a cause for the melatonin cycle, yes, they can have some effect. And occupational glasses do help. That has been documented very well. Rather than going for a progressive lenses, occupational glasses can be of more of help. Artificial tears, definitely they work as vitamins for the eye for this computer vision syndrome, not only as a dry eye substitute, but also when you start prescribing the artificial tears for this patient, they actually provide a break in the continuity of the screen uses. So indirectly also they help, and they have been documented to increase the tear scores and the tear breakup time in a few of the studies. Thinking exercise, as advocated by Kim et al., of closing eyes for 2 seconds, then opening eyes, then again closing it, then again opening it, and squeezing it for 2 seconds and repeating this exercise. This has again been documented to have good improvement in blinks and the symptomatic improvement in the patients. Now, this is one of the most talked about features, the 20-20-20 rule, and as proposed by Ansel, but it has taken some backbeating of now. So like many authors have propagated it, but it provides relief from the computer vision syndrome, but equal number of authors have also refuted it based on like the duration and what it actually, whether it is helpful or not. So one study by Esterels et al. Actually mentioned that it is effective if used for more than 2 weeks, but the effects wean off very quickly if you discontinue it, and the effects wean off in just 1 week or less than a week's time. So it is like a strategy that has to be followed on. That is what I believe it can be if we can just implement it and continue with it rather than discontinuing it in between or intermittent uses. That won't help for the 20-20-20 rule. As a practical thing that I came across was like one of the patients I had from PCS actually mentioned that during their work hours, like it was like 5-6 years ago. So they used to have the screens blanked out after 20 minutes or 30 minutes. So for 20 seconds to implement this rule, and that was there. So though it was like irritating when they are in a task, but it did provide relief. So if it can be stuck up as a policy and can be followed continuously rather than intermittently, it can be of use. So and Datta et al. Have documented its use and utility, but Johnson et al. Specifically mentioned it that since the duration is not very well documented as to whether it is should be for 5 minutes, 10 minutes, 20 minutes. So the evidence regarding that is lacking. So I think the experts can comment on it in a more comprehensive way. So still, I would say that the 20-20-20 rule stays, and it should be followed, and it can be extended actually to the 520s. Apart from the 320 rule of looking at something 20 feet beyond for 20 seconds after every 20 minutes of screen uses, what we have to do is keep the screen 20 feet 20 centimeter from your eyes and 20 degrees inclination. So these are the the two other 20s that have been added. The brightness contrast have to be adjusted accordingly. There have been studies which have documented uses of oral omega-3 supplementation for 45 days to 3 months with improved dry eye symptoms even in computer vision syndrome. That is like more related to the dry eye being um, coming up as the inflammatory cascade sets in because of the evaporative part. The mucin 4A5 gets disrupted, and that translates into a inflammatory cascade. So that can have a role, but oral vary extract have been refuted to have any effect in these cases. So to sum it up, so optimizing screen viewing, the changes in ergonomics, uses of a common occupational glasses, artificial tears, they can all be helpful, and they should be made as a norm to help out these patients of computer vision syndrome. To sum it up, so it is definitely and will continue to be a major health concern, seeing the digitalization that is on a rapid scale, and the postgraduates are no aloof to it. Visual impediments are detectable and correctable, so we can help them out there with the personal impediments that have and the ergonomics that can be changed. So just as we leave it as a school of thought. So while we are so much into gadgets, there's one school in Silicon Valley where all the employees of tech giants Google, Apple, and Yahoo go, and it has got not a single screen or computer inside that. That is something for us to ponder upon where we have evolved. Thank you.
Thank you, Dr. Abhishek, for that very excellent and comprehensive talk. So you gave us a very nice insight into computer vision syndrome and strategies, to tackle this problem. So I now invite our panelists to give their comments and inputs regarding computer vision syndrome. So I first invite Dr. Vinay Pillai. Dr. Pillai, would you like to add something to this? And also, I'd like to know from you, what is your strategy and how do you counsel patients whenever you come across a patient with computer vision syndrome?
Thanks, Dr. Tinku. I hope I'm audible there.
Yes, loud and clear.
Yeah, quite a comprehensive presentation on CVS. So basically, when a patient comes with a symptoms, probably we may have to go in a stepwise manner. The question is, do have a great role here in these conditions. The first step for me will be to kind of rule in or rule out a tear film related problem. So that will be the primary aim or the first step here. Once we know, for that we know all the kind of gadgets, the workup, the basic clinical evaluation does help. And then the other thing which many of us, fail to recognize is a proper cycloplegic refraction here. Okay, that is a very important step here to give proper refractive correction to these people. And then we have to address all the, the ergonomics, the real screen related problems. So in short, it has to be a comprehensive approach here. Along with cycloplegic depression, I would advise a proper orthoptic evaluation also here. Okay. So these are the three things I do for most of my cases who comes. It's little time consuming, and there'll be a couple of visits for these patients because cycloplegic refraction, you do an orthoptics only after doing a proper cycloplegic refraction, not prior to this in most of these cases. So yeah, that little difficult situation is there. But then a person who is really symptomatic, I think, needs to undergo all these things.
Thank you so much. Dr. Bhaskar, would you like to give any comment on this?
I mean, thanks, Dr. Abhishek. This was a very wonderful lecture. I mean, it's an eye opener to everybody, not just the PGs. I think a lot of us also would not have read or gone through the literature that you showed. So there are two aspects to CVS. What is commonly we look at is, say, a dry eye related thing because of blink, because of the Meibomian gland dysfunction, which is probably the subset of patients who would come to us. The second subset is the patients in terms of, like you said, highlighted post COVID, an increase in myopia in pediatric age group, a lack of sleep, anxiety, loss of concentration. This is subtle signs because we are altering the way that our visual signals are being transmitted to the brain at a biochemical level in terms of melatonin secretion, which affects all these parameters. So this is a field about which we are still getting a lot more information on, and our understanding is going to kind of evolve. So when you're looking at a clinical practice, you're probably going to get a patient who specifically comes with a complaint. Like when I said, you rule out any dry eye related issue and then work on the ergonomics. But as a society and as ophthalmologists, we need to make our patients aware about reducing gadget time as much as possible. The 20-20-20 rule is not with respect to the actual time, but it basically tells you or emphasizes the fact that you need to break the concentration on the screen, give your eyes a break, focus on something else, blink consciously. That's something that you would probably want to discuss at this point with anybody walking into the clinic, because all of us are working on gadgets more than 4 hours a day. This webinar itself is 3 hours.
Yes. So, Dr. Srinivasan, there's been a lot of talk, even Dr. Omkar mentioned about the blue light blocking glasses. So they do affect the melatonin production, we know. But when your patient asks you that, doctor, should I go for a blue light blocking glasses? What do you tell them?
So I mean, till I read the literature about a year and a half, 2 years back, I was quite skeptical about it, and I said that it probably doesn't make an effect, as because even the understanding for us as ophthalmologists about the other effects is only coming up recently over the last 5-6 years, that the understanding about how these work has come up. So I would have said that it doesn't make a difference. Now what I tell them is, yes, you could probably use it, but more importantly, you would probably want to not get exposed to the screen at a fag end of the day. Unfortunately, with a lot of people in software industries, because of their time constraints, are also actually working late during your general ideal diurnal circle is kind of getting destabilized. That itself will also affect the melatonin secretion. So how exactly the blue light will affect, or it is actually our diurnal variations which is actually causing a problem, is again something that we still need more clarity and information on.
Thank you. Dr. Wazirani, I now invite you to give your inputs if you're there. Dr. Wazirani is busy in another meeting. So thank you all. Thanks all the panelists for your excellent comments. And I once again thank Dr. Omkar for that wonderful talk. And now we move on to our third talk of this session. I'll just share my screen. That will be by Dr. Dasari Gayatri. So to give you an introduction to Dr. Gayatri, she is a professor at the Geetam Institute of Medical Sciences and Research at Visakhapatnam. And she's been there since February 23 till date. She is an alumnus of the Andhra Medical College at Visakhapatnam. And her areas of specialization are cataract, cornea, medical retina, general ophthalmology. And she also specializes in hospital administration. So I invite you for your talk, Dr. Dasari. And Dr. Dasari will be speaking to us on meibomitis, another very common condition that is of relevance to, I think, every ophthalmologist. So welcome, and over to you.
Thank you, ma'am. Good morning, everyone. Thank you for giving me another opportunity in AIOS GuruSangam. And I'll be sharing my screen. So my topic is meibomitis. No financial disclosure. Meibomian glands are named after Dr. Heinrich Meibom, who is the German physician and first described the Meibomian glands. Corben Henrik Quiz coined the term Meibomian gland dysfunction. Coming to the anatomy, Meibomian glands are sebaceous glands in the eyelids, and there are around 30 to 40 glands in the upper lids, which are 10 millimeters in length, and lower lid consists of 20 to 30 glands, which are 6 millimeters in length and occupies the full thickness of the tarsal plate and arranged in a single row perpendicular to the lid margin. Orifices emerge posterior to the eyelashes, anterior to the mucocutaneous junction. Each meibomian gland consists of 10 to 15 acini, which contains the meibocytes, lateral ductules, a central duct, and a terminal excretory duct, which opens at the posterior lid margin. Coming to the acinus, as each acini contains meibocytes which produce the lipids and which mostly contains the natural sterol and the wax esters. The ductal system comprises of connecting ductules and long central duct, which is lined by 4 layers stratified squamous epithelium, and the excretory duct represents an extension of the skin. Stem cells are found near the ductal and the acinar basal cells where they meet, and they are responsible for continuous self-renewal of the lipid-secreting meibocytes. Role of blinking. Pretarsal orbicularis oculi coaxes the secretions into the lid margin during blinking. Rheolens muscle, which is orbicularis fibers which extend to the eyelid margin, these compress the ducts and the acini to deliver the secretions effectively. Blinking is essential for releasing the meibomian gland lipid into the tear film, distributing the lipid layer, and lack of blinking leads to the gland engorgement. Abnormal blinking patterns are linked to meibomian gland dysfunction. Innervation of meibomian glands. Meibomian glands are supplied by parasympathetic nerves that are cholinesterase positive and which contain vasoactive intestinal polypeptide. Sympathetic and sensory nerves are present, but they are sparsely distributed. Neuropeptide Y positive nerves are abundant. Tear film lipid layer. It is the outermost layer of the tear film, and the thickness varies from 40 to 100 nanometers. It contains of 2 layers. Outer is the non-polar layer, which functions as a lubricant and the water barrier, which prevents the tear evaporation. The inner one is the polar lipid layer, which acts as a surfactant to ensure the lipid layer spreads across the ocular surface. It contains 30% sphingolipids, which are elevated in the MGD and increases the melting temperature. Lipid levels are higher shortly after waking due to the glandular engorgement during sleep and are released upon blinking. Tear film lipid layer functions are to provide a smooth optical surface, to reduce the evaporation of the tear film, to enhance the stability and spreading of the tear film, to prevent the spillover of the tears from the lid margin, prevent the contamination of the tear film by sebum, and to seal the opposing lid margins during the sleep. Coming to the meibomian gland dysfunction, the International Workshop of Meibomian Gland Dysfunction defined meibomian gland dysfunction as a chronic diffuse abnormality of the meibomian glands, commonly characterized by the terminal duct obstruction and/or qualitative quantitative changes in the glandular secretion. Any alteration in the tear film causes symptoms of the eye irritation, clinically apparent inflammation, and ocular surface disease. Prevalence of meibomian gland dysfunction, which is a common cause for evaporative dry eye disease, and it is more common in the Asian population with prevalence rate exceeding 60%. In Caucasian population, it is approximately 20%. In a recent hospital-based study in India, which is conducted, shows the prevalence rate of 55%, and other community-based studies in India reports the rates around 30%. The risk factors are androgen depletion conditions, systemic conditions such as aging, Sjogren syndrome, Stevens-Johnson syndrome, psoriasis, atopic PCOS, hypertension, systemic medications such as retinoids, antibiotics, antihistamines, antidepressants, hormone replacement therapy, Topical medications such as epinephrine, which causes duct hyperkeratinization, and glaucoma medications, which cause gland loss. Nutritional deficiency of omega-3 fatty acids, and infestations with Staphylococcus aureus and Demodex folliculorum, and contact lens wear causes gland dropout and inflammation. Congenital factors such as gland absence, such as in Turner syndrome, and replacement in distichiasis. Other ocular risk factors are chronic blepharitis, trachoma, eyelid tattooing, and aniridia. The pathophysiology of MGD: obstruction of the Meibomian gland ducts is caused by the epithelial hyperkeratinization, which blocks the ducts and leads to the meibum stasis and increased viscosity, cystic dilatation, and acinar atrophy. Meibocyte abnormalities are caused by dysregulated differentiation and renewal of the meibocytes. Decreased stem cells reserves result in gland loss and dropout. These impact the meibum secretion and causes dry eye and short tear film breakup time. There are two models which describe the mechanism of the tear film disruption. That is the lipid contamination model and the mucin rupture model. Lipid contamination model: a deficient aqueous subphase allows the lipid layer to contaminate the mucin layer, making it hydrophobic and causing the tear film instability. Mucin rupture model: it is the key step in tear film breakup, occurs due to van der Waals expulsion process disrupting the mucin layer. The next slide, it's not moving. Can you hear me?
Yes, we can hear you now. Yeah.
The slide is not moving.
Yeah, the slide is not.
Just click on the slide, ma'am. Just click on the slide. It should move. Just click and start moving the slides up and down. Or you can stop and reshare. Yeah, it's moving.
The melting point of the meibum secretions ranges from 32 degrees to 40 degrees. Chronic marginal blepharitis raises the melting point and causes stagnant secretions. Warm, moist compressed therapy can lower the melting point and increase the tear film lipid thickness by over 80%. Oh God, it's not moving again.
You can share again, I think.
It's visible, ma'am.
Yeah, but it's not moving.
Just click on the slide. Yeah, moving, ma'am. Perfect.
I think there's internet problem. Coming to the classification of MGD, which is proposed in International Workshop of MGD, the Meibomian gland disease is categorized as congenital neoplastic Meibomian gland dysfunction, acute, and others. It is Meibomian gland dysfunction is again divided into two states: low delivery state and the high delivery state. Low delivery state is again of two types: hyposecretory, which the reasons may be primary or secondary due to medications such as retinoids, and obstructive is again two types: cicatricial and non-cicatricial. Cicatricial, primary, and again secondary. Secondary causes are trachoma, ocular pemphigoid, erythema multiforme, and atopy. Non-cicatricial, again primary and secondary. Secondary causes are seborrheic dermatitis, acne, rosacea, atopy, and psoriasis. High delivery states are again categorized into primary and secondary. The secondary causes are seborrheic dermatitis and acne rosacea. So coming to the symptoms of MGD, they are foreign body sensation, burning, tearing, sensitivity to light, irritation, itching, and unstable or fluctuating vision. The signs of MGD, the lid margin features are irregular lid margin with dimpling, notching, thickening of the lid margin, vascularization of the margin, displacement of the mucocutaneous junction. The Meibomian gland features are epithelial ridge linking the gland orifices, meibum or keratin plugging of the Meibomian gland orifices, spouting of the gland orifice, stenosis and obliteration of the gland orifice, and concretions. And the meibum quality is also altered, and the meibum expressibility is also difficult, and the quality may be discolored, turbid, or debris-filled material, or toothpaste consistency. Tear film, they may be debris or foamy secretions, and instability, which is measured by the tear breakup time. Ocular surface, staining of the conjunctiva and cornea, and inflammation of the ocular surface is evident. These are the clinical subtypes of the MGD. MGD is, the clinical types are MGD alone, MGD associated with ocular surface damage, MGD related to evaporative dry eye, and MGD associated with other ocular disorders. Again, MGD alone is categorized into asymptomatic and symptomatic. Asymptomatic, there will be altered Meibomian gland expression, whereas symptomatic is again of two types, non-cicatricial and cicatricial. And there will be evident symptoms and signs of the Meibomian gland dysfunction. MGD associated with ocular surface damage, there will be positive staining in the lower conjunctiva and the cornea. And MGD related evaporative dry eye, the dry eye test will be altered, like decreased tear breakup time, and Sherman's test can be normal in MGD or little reduced. Meibomian gland dysfunction associated with other ocular disorders are Meibomian gland keratoconjunctivitis, which is associated with chronic blepharitis, and Meibomian gland and contact lenses, there will be contact lens intolerance and giant papillary conjunctivitis, and mixed anterior blepharitis and Meibomian gland dysfunction, usually seen in seborrheic or atopic blepharitis. Coming to the test for MGD, for asymptomatic MGD, we can do only gland expression by putting a digital pressure in the central lower lid and see for the expressibility and the meibum quality. For symptomatic patients, we have, along with the Meibomian gland functionality assessment, we have to see for the orifices, and further ocular surface damage and dry eye tests also we have to do. First test for the MGD related dry eye, it is of two-tiered approach. First step, we have to distinguish between normal versus dry eye patients. Second step, we have to differentiate whether it is MGD related evaporative dry eye or aqueous deficient dry eye. So the clinical setting is different in general clinic and specialized investigative units such as cornea units, which are well equipped with advanced equipment. So the sequence of tests for a symptomatic patient in general clinic is different, and in an MGD related specialized unit is different. So in general clinic, first is administer the symptom questionnaire, commonly OSDI questionnaire. We have to measure the blink rate, blink interval, lower tier meniscus height by in slit lamp, and if possible, measure the tear osmolality with the tear lab device, and ocular surface staining using the Oxford grading system and the dry eye workshop grading, and see for the tear breakup time and non-invasive breakup time, fluorescent breakup time, and Sherman's test, and quantify the lid features, expressibility of the meibum, its quality. If possible, if meibography is available, assess the gland morphology, the acinar cell density, the periductal inflammation, fibrosis. Whereas in a specialized unit, there may be extra equipment which is available to measure the tear osmolarity, tear volume, evapometry, and other for bioinflammatory markers can be assessed. So this is a slide which shows you the equipment which is needed in a general clinic and in a specialized unit for MGD. A little brief note about the equipment used in the MGD. Lipid layer interferometry, it measures the thickness of the lipid layer of the tear film. Thick lipid layer indicates stable tear film. Thin lipid layer indicates unstable tear film. Meibometry, it quantifies the basal meibum levels at the eyelid margin. And the meibum is transferred to a specialized tape, which is again analyzes the transparency photometrically. And meibography visualizes and assesses the morphology of the Meibomian glands. And there are various types of meibography, that is contact meibography, non-contact meibography, and advanced imaging techniques such as optical coherence tomography meibography. And easiest method of doing meibography, that is the trans-illumination meibography. You can use a small red LED bulb which trans-illuminates the everted eyelid, and the image is captured by a specialized camera. And we can assess the Meibomian gland morphology, duct dilatation, gland loss, and we can grade it by Erita et al.'s grading. That is, grade 0 means no loss of Meibomian glands. Grade 1, area loss of less than 1/3 of the total MG area. And grade 2, area loss between 1/3 and 2/3. Grade 3 means area loss more than 2/3. And we can sum up the scores and grade the Meibomian gland dysfunction. Management of Meibomian gland dysfunction. The treatment plan is based on the staging of the disease. The disease is staged in 1, 2, and 3, 4. Depending upon the expressibility of the glands and the meibum quality, the symptoms, and the corneal staining. So how to grade the meibum quality? We have to assess the 8 glands of the central third of the lower lid. And grade 0 means clear meibum. Grade 1 is cloudy meibum. Grade 2 is cloudy with debris. And grade 3 is thick like toothpaste type of consistency. And we have to assess the expressibility in 5 glands in the lower or upper lid. Grade 0 means all glands are expressible. Grade 1 means 3 to 4 glands are expressible. Grade 2, 1 to 2 glands. And grade 3, no glands are expressible. And we can score the ocular surface staining of the exposed cornea and conjunctiva by Oxford staining score and the Deuce staining score. This is the algorithm for the MGD treatment. Stage 1, where there is no signs, you have to inform the patient regarding the potential effects of MGD and change the diet and lifestyle modification, and consider lid hygiene using the lid warm compressors and expressibility. Stage 2, where there are minimal to mild symptoms. In addition to the education of the patient regarding the environment changes they have to do, and we have to supplement omega-3 fatty acids and ensure eyelid hygiene. And we can add artificial lubricants, which are preservative-free, topical azithromycin, topical emollient lubricant. And coming to stage 3, where there are moderate symptoms and signs, along with the previous treatment, we have to add oral tetracycline derivatives, lubricant ointment at the bedtime, and anti-inflammatory therapy for dry eye if there is any inflammation. Stage 4, where there is marked symptoms and severe signs, along with the above treatment, we have to add anti-inflammatory therapy for dry eye. And there is something called plus disease. Along with the Meibomian gland dysfunction, there can be exacerbated inflammation of the ocular surface, mucosal keratinization, flectinular keratitis, trichiasis, chalazion, anterior blepharitis, and Demodex-related anterior blepharitis. For this, the underlying cause should be treated along with pulsed soft steroids, BCL, scleral contact lenses, epilation, topical antibiotics, and T3 oil scrubs for the Demodex. So for postgraduate sake, I have again divided the treatment strategies into conservative methods, medical therapies, and the procedures. And I have also included the emerging therapies in MGD, and I like to explain them one by one. Lifestyle modifications are you have to ask the patient to optimize the work or home environment, intake of healthy diet, avoid smoking, improve the body hydration status, adopt methods to decrease the excessive evaporation of the tear film, avoid hot, dry environments, and use wraparound style glasses on windy days. Add moisture to the ambient air using humidifier, and avoid direct blast from the air conditioning or the heating vents. And coming to the lid hygiene, why it is useful? It reduces the toxic lipids, free fatty acids, and decreases the bacterial load at the lid margin. We have to do warm compresses, which liquefies the thickened mebum, and with the water soak cloths in the warm water. And lid massage, it is performed after heat application to evacuate the gland secretions. And lid scrubbing, it removes the debris and cleans the gland orifices. We can use a diluted baby shampoo with low irritation potential. Coming to the medical management, lubricants, it acts as a supplement of the tear film in evaporative dry eye disease, and a lubricant eye ointment is used at bedtime for symptomatic relief. Use of vanishing preservatives like sodium chloride or sodium perborate prevents the preservative-induced epithelial toxicity. And the new therapy is use of lipid-containing eye drops and liposomal sprays, which delivers the lipids directly to the ocular surface. Antibiotics, as we know, bacteria produces toxic products such as lipases and releases the pro-inflammatory molecules. The antibiotics commonly used in MGD are tetracyclines and azithromycin. Tetracycline, which has both anti-inflammatory and antibiotic property, it suppresses the bacterial lipase production and the pro-inflammatory molecules. The side effects are photosensitivity and gastrointestinal symptoms, and it is not suitable for pregnant women or children. Commonly used tetracyclines are doxycycline, which is 100 milligrams orally once daily for 4 to 6 weeks, and minocycline, 50 to 100 milligrams orally once daily for 4 to 6 weeks. Azithromycin, it is a macrolide antibiotic used off-label for MGD. It promotes differentiation of Meibomian gland cells and stimulates the phospholipidosis, promotes the carotenoid differentiation. It is available both in topical and oral forms. Topical azithromycin 1% applied daily in the night for, you can use it for 3 months depending upon the stage of the disease. And oral azithromycin 500 milligrams on day 1 and 250 milligrams on day 2 to 5. I like to add, I have done a study with oral azithromycin. This is a short pulsed course where on day 1 we give 500 mg and on day 2 to 5 we give 250 mg. We have done a study on cataract, the patients who come for cataract surgery and they have MGD, so we have to postpone the surgery. So we have advise this pulsed dose along with warm compresses, lid hygiene, and topical azithromycin and lubricants. And when they came for 2 weeks follow-up, there was really favorable responses. And instead of postponing the surgery for a long time, giving doxycycline for a prolonged course, we can use this oral azithromycin short pulsed course so that we can operate the cataract surgery patients quite early. But we have to avoid the oral azithromycin in cardiac patients who have long QT intervals because they can precipitate into cardiac failure. Coming to the anti-inflammatory agents, the elevated levels of the phospholipase A2 in mebum contributes to the synthesis of the inflammatory mediators like prostaglandins and leukotrienes. So the anti-inflammatory agents contract these inflammatory processes. Commonly used are cyclosporin A, liftigrast, corticosteroids, and anakinra. So cyclosporin A 0.05% is FDA approved for the dry eye disease. It inhibits the calcineurin, reduces the interleukin-2 production, T cell activation and proliferation. We can use it twice daily. The side effect is a stinging sensation, but pre-treatment with topical loteprednol 0.5% reduces the stinging. Coming to the liftigrast, it is a lymphocyte function associated antigen 1 antagonist. It blocks the T cell binding to the intercellular adhesion molecule 1 and prevents the release of the pro-inflammatory cytokines. FDA approved liftigrast 5% for the dry eye disease. There is a trial which is OPUS phase 3 trial, which has shown that twice daily liftigrast 5% used for 12 weeks has outperformed the placebo. And coming to corticosteroids, there is no evidence which supports long-term maintenance therapy with steroids, but it is beneficial for acute inflammatory ocular surface conditions. And RCT showed that treatment with 0.5% loteprednol ethambutate bonate with which is used 4 times per day, along with the eyelid scrubs and warm compresses, has improved the tear breakup time and mebum quality. So this is the emerging therapy, which is anakinra, which is a recombinant version of IL interleukin-1 RA, this is approved for the rheumatoid arthritis and used off-label for dry eye disease. An RCT was conducted which showed that topical anakinra 2.5%, which is used 3 times daily for 12 weeks, significantly reduced the symptoms and corneal epitheliopathy in dry eye disease, which is associated with Meibomian gland dysfunction. Hormone therapy, androgens are shown to promote the lipogenesis and increase lipid secretion, and deficiency or receptor dysfunction is linked to the Meibomian gland dysfunction. The hormone replacement therapy effects on Meibomian gland dysfunction is variable. One study has showed that postmenopausal women on HRT have a higher risk for dry eye. Some studies showed that there is symptom improvement with HRT, but there is less literature available recommending the HRT. And coming to the androgen therapy, there is an RCT which shows that topical 0.03% testosterone significantly improved the Meibomian gland secretion viscosity in a 6-month period. Coming to the essential fatty acids, oral supplementation with omega-3 fatty acids changes the fatty acid saturation content in the meibum and has the anti-inflammatory effects. And but omega-6 fatty acids increases the inflammation. There is a study which is DREAM study, means dry eye assessment and management study. They found that no significant difference is present with omega-3 fatty acid supplementation and placebo for a period of 12 months. So there is a conflicting evidence on effectiveness of omega-3 supplementation. Coming to Demodex treatment, Demodex folliculorum is found in the lash follicles, and Demodex brevis is found in Meibomian glands, and presence of Demodex is seen in 60% of MGD. The Demodex physically blocks the Meibomian gland and results in granulomatous reaction. So tree tea oil is recommended, which is derived from leaf of Melaleuca alternifolia. So 1 month treatment of weekly 50% TTO lid scrubs or 10% daily have shown to eradicate the ocular Demodex. Other agents to treat the Demodex are mercury oxide 1% ointment, sulfur ointment, pilocarpine gel, camphorated oil, and oral ivermectin 200 microgram per kg on day 0 and day 7. The procedures which are used for MGD are electronic heating devices. The temperatures more than 40 degrees are required to liquefaction of the obstructive glandular material. The two devices which are available are LipiFlow and Meibothermoflow. LipiFlow shows the procedure is simultaneous application of the heat to the palpebral conjunctiva of the upper and lower eyelids, along with distal to proximal pulsatile pressure to the outer eyelid to express the Meibomian gland's contents. A single treatment is 12 minutes in duration. Another device available is Meibothermoflow, which uses an external paddle heated to 42.2 degrees centigrade, and it is applied to the lids with the ultrasound gel buffer. Coming to intraductal Meibomian gland probing, it is performed at slit lamp. The procedure is mechanical opening and dilating of the blocked Meibomian gland orifices and ducts through the insertion of probe. Initially penetrated using a 1 or 2 millimeter masking probe, which is followed by either 4 or 6 millimeter probe, depending on the length of the gland. It releases the accumulated meibum, improves the ductal patency, increases the accessibility of the Meibomian gland to the topical treatment. Coming to intense pulsed light therapy, the FDA has approved an IPL device from Luminis for treating the dry eye disease. It uses a xenon flash lamp, which emits a filtered polychromatic broad bandwidth wavelengths between 500 to 1200 nanometers for selective photothermolysis. Damage to specific chromophores such as melanin and hemoglobin causes coagulation and thrombosis of the blood vessels. This therapy was initially used for the dermatology, and in MGD we can use it, which causes evaporative dry eye. The benefits in MGD is thrombosis of the abnormal blood vessels, that is lid telangiectasia, heating and liquefaction of the meibum, local photomodulatory effects, activation of the fibroblasts, enhancement of the collagen synthesis, and destruction of the demodex mites. So clinical studies have showed that IPL reduces the tear concentrations of the interleukin 17 and interleukin 6 after 3 treatments, and along with gland expression improves the symptoms in MGD in 89% of the patients. The adverse effects are it causes mild redness and swelling in 13%. We have to avoid sun exposure, retinol therapy, photosensitizing medications such as tetracyclines, isotretinoin prior to the treatment. And last one is the intranasal tear neurostimulation. It uses the nasolacrimal reflex via pulse stimulation of the anterior ethmoidal nerve. And animal studies have showed that daily 3 minutes application for 3 weeks increases the tear volume and decreases the tear osmolarity. And some human studies have showed that induces the degranulation of the conjunctival goblet cells, improves the Schirmer scores, alters the gland morphology and lipid layer thickness, indicating the meibum release. Thank you.
Thank you, Dr. Gayatri. That was a very comprehensive talk. I think you covered all the aspects of meibomitis, right from the anatomy to the etiology to the management strategies. So I congratulate you for the excellent talk. And with that, we move on to our panelists for their comments and any inputs that they would have. I'd first invite Dr. Vanati, if you have anything to add to this, I request you to chip in. Dr. Vanati.
Hi. Yes, Doctor. I think Dr. Gayatri almost, she comprehensively covered an extensive review article on Meibomian glands, I should say. And I think increasingly ophthalmology practice is focusing on the health of the lid for almost all kind of ocular problems which we are seeing out here. And many a time we try to trivialize the Meibomian gland pathologies, and I think with increased understanding and our evolving understanding of further pathologies, we are able to more effectively treat most of the disease conditions here. But I think Meibomian gland disease needs particular attention when you're managing cataracts, when you're managing glaucoma surgeries, and more importantly, for refractory surgeries here. These are where they are going to be of particular problem, and the health of a Meibomian gland, especially if it is a moderate to severe disease, needs to be well managed before you're advising the patient any surgical intervention. I think Gayatri has not left out anything in the way of how you would need to look at Meibomian gland disease and all its current advancements as well. And this is a very important topic which all practitioners and postgraduates need to be well versed about.
Dr. Vanati, a word about lifitegrast eye drops. So I think there was a recent publication that has come out from center on this eye drop.
Yeah. See, I'm yet to have personal experience on the use because it's just recently been, it's recently available in India for widespread use here. So I really can't comment on personal use on what's there in literature. I think all of us have read about it here. So its role in inflammatory eye disease is something which we'll probably be able to share my experiences shortly, perhaps by the end of this year.
But it's available in India, the site.
Yes, it is.
Dr. Jayesh, I would invite it is. Dr. Jayesh, I would invite your comments on this talk. If Dr. Jayesh is there, I know he's busy in another conference. So, Dr. Bhaskar.
Yeah, I mean,
I request
a very well covered talk on not just MGD but on the way to manage dry eyes in general. A couple of things. We do have a lot of gadgets to evaluate dry eye, to evaluate MGD, but you still need a very good history taking and a good clinical evaluation, which will actually help you manage most patients. If you don't have access to a meibography, you don't have access to a lippy view, which gets your lipid layer thickness. Also, looking at the Meibomian gland in terms of the amount of glands that are open, the consistency of the meibum that comes out by just pressing the lids gives you an assessment, and the tear breakup gives you an assessment about the status. So it's not from a postgraduate point of view, it's not that you need to have all the latest gadgets to diagnose or treat a dry eye disease. A clinical evaluation, looking at the lids, a strip of fluorescein and staining the ocular surface to look at any stain, to look at the type of breakup and to look at the pattern of breakup tells you to a certain extent which component of dry eye is you're dealing with. This has been the basis of the Asia Dry Eye Society. Yes, it is difficult to identify all the patterns, but it kind of gives you some idea in terms of how you would want to look at that particular patient. So any patient who walks into your OPD or you're seeing, fluorescein staining has to be a part of your regular checkup, whether it is a cataract patient, whether it's a refractive surgery patient, or it's a general checkup. The patient who walks in, a drop of fluorescein to estimate the breakup time, to estimate how the fluorescein moves up as the patient blinks, to look at the pattern of the breakup, and then you end up with pressing the Meibomian glands to look at the secretion. You also look at the lacrimal gland flow to kind of give you an assessment whether the Schirmer's, the TMH, the lacrimal gland flow, everything fits into pattern. You look at the breakup to identify whether there is an aqueous deficiency component which is causing the breakup faster, or it's an evaporative component. This gives you an overall picture of the dry eye status, and then you can plan your treatment accordingly. The only when you're looking at publications and when you're looking at investigations, the problem is the ocular surface is such a volatile environment. If you are looking only at one value of lipid layer thickness, if the patient blinks 10 times and then you're evaluating it, the value is going to be different. So if you're looking at a lippy view report, you have 3 parameters. You look at the number of blinks, you look at the completeness of the blink, and then you look at the value. Unless if you look only at the value, then it will be an erroneous pattern that you would get. Again, even though we like to split it into lipid and aqueous, it's always a combined unit. So if you have a severe aqueous tear deficiency with the staining of the ocular surface, the value that the lipid layer thickness machine gives you might actually be erroneous. It might give you a value higher than 100 because it's now forming blobs. It's not able to coat the surface as well. So you might actually get a value which seems higher than what, or a normal or a higher value than the value that is there. So you will always take those values as something as a guide, but it's not, unless you do a proper clinical evaluation, you cannot fit the jigsaw in place.
Dr. Bhaskar, which are the cases that you would prescribe these soft steroids to? To all cases or to severe cases, or do you have any criteria?
So the idea, I mean, if it's a pure dry eye patient, if you divide it into say an aqueous tear deficiency specifically, or you look at say an Meibomian gland dysfunction. For a Meibomian gland dysfunction, if there's a significant lid inflammation, yes, I would probably give an antibiotic steroid combination that will reduce the load of the bugs, which are the commensals, which have increased in number, and that is causing a change in the meibum quality. So it will address the bugs, it will address the inflammation which is secondary to the bugs. If it's an aqueous tear deficiency like a Sjogren's patient, I might use steroids, but in a very judicious form, because if there is inflammation, I would want to address it with the steroids for maybe about 2 weeks or so, but I would want to go into the root cause. In that case, I would want to consider starting the patient on topical cyclosporine. Now, if it's the fag end of the disease where it's more the dryness which is causing the inflammation on the ocular surface, like your Schirmer's is 0 or 1, and the ocular surface is red and inflamed, and there's a lot of staining on the surface, then steroids are only going to be a temporary measure. It's not really going to solve the problem. There you would look at either giving the patient a scleral contact lens, or you would want to look at blocking the puncta, because you want to retain the tears on the ocular surface. So identifying the stage of the disease where you are dealing with, whether you're dealing with the early stage of the disease where you still have the lacrimal gland has the capacity to secrete tears, because what was worried was the fact of a toxic tear syndrome where you have increased inflammatory cells on the ocular surface and you don't want to block the puncta and cause more inflammation. So in an early stage of the disease, where the cells are being secreted, yes, you don't want to block it. But once the lacrimal gland secretion is completely knocked off and it's only primarily the friction which is causing the inflammation, you need to retain the tears on the ocular surface. You would need to look at strategies to block the drainage opening so that you get a better control over the ocular surface inflammation.
Thank you. Thank you so much. With that, I move on to Dr. Vinay Pillai for his comments and inputs. I invite you, Dr. Vinay.
Yeah, quite a comprehensive presentation here. I mean, very little to add to whatever has been described here. So what is more important here is to identify the condition in these cases, especially in, pre-op conditions. So, understanding that there is an disease entity like this, to look at, the lid margin before looking at the lens is what is more important here. And once condition, then as Bhaskar said, we have to, have a proper evaluation, assess the health of ocular surface, how bad is the lid margin, and then decide on the treatment accordingly. A kind of, stepwise approach will be good here.
Okay. So I'd just like to ask you, like Dr. Gayatri mentioned, that the DREAM study has shown no added benefits of omega-3 fatty acids in this condition. So do you still continue to prescribe omega-3 fatty acids? And
in very limited patients. I mean, if you ask me what is the exact indication I would give, probably, slightly younger patient with altered secretion who are quite symptomatic, probably this might have a role.
So I'd ask the other panelists also, Dr. Vanati, do you still prescribe omega-3 fatty acids? And Dr. Bhaskar? Okay. So, but I mean, in all cases, do not need to. I'd just like to go back to Dr. Sridhar. Would you like to comment on that? The role of omega-3 fatty acids.
I think Vanati is back.
Yeah.
Omega-3 fatty acids, as Vinay said, not in all cases, not in Meibomian gland disease, but in aqueous deficiency. I don't know whether it's placebo or not, whether macuberry or omega-3 fatty acid seems to have a beneficial effect in a few patients. So I would not step back if the patient says it benefits them, and so be it. So I think Vanati will be able to comment on studies which have.
I think a few years ago we were, rarely writing omega-3 fatty. Do you still?
Absolutely. I think we were glued on to omega-3 fatty acids for dry eye disease primarily. So if you're looking at a Meibomian gland being causative for a dry eye disease, and Meibomian gland dysfunction largely attributes to an evaporative kind of dry eye disease, or there could be a combination of the etiologies here. But I think by and large, the current level of evidence does not point to a beneficial role of omega-3 fatty acids in dry eye disease as being a therapeutic agent here. So probably it could be one of the cofactors when you're managing a particular disease, but it's not really a beneficial one. So I have almost stopped prescribing omega-3 fatty acids for my dry eye disease patients here.
Thank you.
It's like vitamin D3 being
Yes.
playing a role in dry eye disease. Anything and everything, there can be a study and say, yes, this is useful.
Yeah.
Dr. Gayatri, you mentioned dietary modifications for meibomitis. So if you could just elaborate on the dietary modifications.
It includes intake of omega-3 fatty acids first one, and healthy diet, lipid source foods.
Okay.
I think you would say, I would tell the patients not to eat chole bhature, Tinku, in North India. That will not make you very popular. But I think in cases of acne, rosacea, where meibomitis is, you would say avoid oily foods in such conditions, you know.
Okay. So thank you everyone for those excellent pointers and comments and inputs. And with that, we move on to our last talk of this session. And that would be by Dr. Uma Sridhar on chemical injuries. So Dr. Uma Sridhar is a senior consultant in the cornea and cataract services at the Eye Care Eye Hospital in Noida. Fellowship trained at the L.V. Prasad Eye Institute, Hyderabad. She's also a fellow of the Royal College of Surgeons of Edinburgh. Her areas of interest and expertise are cataract surgery, cornea diagnostics and surgery, ocular surface disorders, ocular surface tumors, dry eye diseases, stem cell transplantation for limbal stem cell deficiencies. So she has years of experience and she's a very, very distinguished academician. So we look forward to her talk on chemical injuries. So over to you, Dr. Uma.
Thank you, Tinku. I think I will try to screen share now. Yeah. Yeah. Is my screen visible?
Yes, it's visible. Okay. It's not full screen though.
I know this is some issue.
Ma'am, you need to close that Adobe pop-up. If you can just close, you should be able to share.
That stupid thing keeps coming. It doesn't listen to me. Just every 2 seconds, it just
right-click on it and close. Yeah, we are good.
Okay.
Just click on it.
Just one. It's not.
Or just go to the PPT. Just go to the PPT. You can just click on the PPT. Yeah.
1 second. Yeah, I'll do that. Just get it.
Right.
Yeah, good.
Yeah, now you can see my screen?
Yes,
Okay,
ma'am.
great. Right. So acute chemical injuries and their chronic consequences, it's extremely important. We have a great set of panelists who have great experience in this. And you don't want this to reach this stage when coming from this stage. So to avoid this kind of a appearance, we need to manage it in the acute stage well. But of course, when it is of a severe grade, then we may not be able to avoid that. Now, here we find that it is a true medical emergency, and the incidence of chemical and thermal injuries to the eye has been found to be almost 7 to 18% of all ocular trauma. And it can cause extensive damage to the surface epithelium, cornea, anterior segment, lens, iris, even to the retinal ganglion cells, and lead to permanent unilateral or bilateral visual impairment. 80% of ocular chemical injuries are due to industrial or occupational exposure, males more than females. In India, the lime burn or tuna injury is very common. So here we see a spectrum of ocular chemical burns. You can see that you can have strong acids, weak alkalis, and strong alkalis. In all spectrum of our daily life, we come across chemicals which can harm the ocular surface and also systemically can cause harmful effects. So common offending agents at home are cleaning solutions. Very often we come across patients who say that they were using toilet cleaners, drain cleaners, oven cleaners, bleach. There could be very commonly sulfuric acid, battery explosions, and car battery when they are being cleaned. Industrial agents like dye, lime, there's so much of construction work everywhere in spite of the GRAP 3, GRAP 4 in Delhi. Acids like hydrofluoric acid and sulfuric acid and also hydrochloric acid. Now, by opening drains, you can actually cause blindness to the eye. It's not moving like Gayatri's problem here. Shall I stop share and start share again? Excuse me.
Yeah, you could do that.
Yeah, it's moving. So alkali and acid burns. In alkali, you find ammonia, lye, potassium hydroxide, and lime. And among the acid burns, sulfuric, sulfurous, hydrofluoric, and hydrochloric acid. Common sources of chemical injury, like I said, sulfuric acid and battery acid, industrial cleaners, acetic acid, something common like vinegar, glacial acetic acid, hydrochloric acid in labs, sulfurous acid, hydrofluoric acid, glass polishing, etching in alkalis like ammonia in fertilizers, refrigerants, cleaning agents, lime, plaster, mortar, common tuna in the pan that you eat, potassium hydroxide and magnesium hydroxide in sparklers, incendiary devices. So the severity, excuse me, of the injury depends upon the amount of exposure, the type of chemical, the volume of the chemical, the concentration, and the duration exposure. So it's an acute emergency. The immediate response would be copious wash with whatever solution is on hand. So what we would look at is what to use, what solution to use, how much to use, and for how long to use. So just to make things interesting, like in last time, some MCQs, if the PGs are listening, they will be able to answer, and the end we'll have the answers. So what is more effective? Tap water, ringer lactate, BSS, diphotherine, or diphotherine, ringer lactate, normal saline, BSS, option C. Excuse me, diphotherine, BSS, ringer lactate, normal saline, or phosphate buffer, diphotherine, BSS, and ringer lactate. So diphotherine may not be available. At the site, whatever solution is available, tap water is hypotonic, so if avoidable, if anything else is available, normal saline, ringer lactate, BSS, polyvalent amphoteric solution like diphotherine. The management in the acute phase would mean loss of solution to wash away the chemical and dilute it. Tap water is available. Disadvantage, it is hypotonic. It is available in the field, and buffered solutions can correct the pH. And the amphoteric solutions like diphotherine, they are hypertonic to the stroma, rapid pH correction, faster reepithelialization, if readily available in the clinical setting. So the importance is the chemical should be diluted and washed off as much as possible. Excuse me, got a bad case of laryngitis, so right. So if you have a Morgan lens, it can be attached, it can be connected to a IV line, can be placed on the eye after putting a drop of anesthetic, and it can be used to copiously wash if the patient is very symptomatic. Now, the second MCQs is the acids penetrate less because of saponification of cell membranes, alkali saponification of cell membranes, acid coagulation of epithelial proteins, or alkali coagulation of epithelial proteins. Which alkali is more severe? Sodium hydroxide, calcium hydroxide, ammonium hydroxide, or potassium hydroxide. So in various combinations, which would be the most potent and which would be the least potent, depending upon the pH. The pathophysiology of chemical injury. The acids cause denaturation and precipitation of proteins on contact and cause a ground glass appearance, but there is a barrier to penetration. The damage to the stromal matrix is secondary to inflammation. But some acids like hydrofluoric acid can still penetrate very deep. Alkalis, saponification of fatty acids in the cell membrane. Rapid penetration, there is damage to deeper structures, even iris, lens, and it can cause severe glaucoma also. Sometimes even the ganglion cell layer can be involved. The alkalis cause maximum damage of in the pH range of 11 to 11.5. They dehydrate cells, destroy enzymatic and structural proteins. Ammonium hydroxide causes rapid penetration, followed by sodium, potassium, and calcium. Heat generated by the chemical reactions cause additional damage. So, excuse me. So each structure in the eye is damaged in a different way. The conjunctiva gets cauterized, the corneal epithelium sloughs, the corneal stroma swells and opacifies. There is endothelial cell damage and death. The angle structure scar and the lens can opacify. Weak acids and alkalis, they can cause injection, chemosis, mild corneal clouding, and edema. Severe acid burns, the cornea and conjunctiva are white and opaque. Nitric and chromic acid, the tissue can become yellow-brown. Severe acids, cornea can get anesthetized. There can be limbal pallor and uveitis. Severe alkalis, they can cause corneal melting and perforation within 2 to 4 weeks. The extent of limbal involvement is important for re-epithelialization. Right. So the fourth MCQ is, which is the most important prognosticating factor after ocular chemical injury? Sorry. Chemosis, conjunctival epithelial defect, limbal ischemia, or corneal epithelial defect. Clinical course of chemical injury, what are the determinants? pH of the substance, concentration, the length of time of contact. The clinical course of chemical injury can be divided into immediate phase, acute, early reparative, and late reparative. The clinical course in the first 7 days, the most important therapeutic consideration is prompt, unhindered re-epithelialization. Whatever the epithelium, whether corneal, conjunctival, or whatever, it is better to have epithelial covering. Otherwise, there can be a stromal melt. The control of ocular inflammation is the second most therapeutic consideration during this period. Also, look at the corneal clarity. Intraocular pressure can rise because of shrinkage of ocular collagen and later because of release of prostaglandins. The clinical course of chemical injury, the early reparative phase, 8 to 20 days. There is chronic inflammation, stromal repair and scarring. The most important treatment goal again is the establishment of an intact epithelium and then the control of ocular inflammation. The clinical course of chemical injury, late reparative phase, 3 weeks after injury, loss of sensation, reduction of blink reflex, decreased tear production. Severe injury can lead to pannus formation, and aim is to maintain epithelialization and lubricate the surface. The key elements for prognosis are the total area of corneal epithelial defect, the area of conjunctival epithelial defect, the number of clock hours of limbal blanching, the area and degree of density of corneal opacification, the evidence of increased IOP on presentation, any loss of lens clarity. The last two elements imply deeper effects of chemical agent and damage to the internal ocular structures. So what do you do for patient treatment and evaluation? The pH strip is extremely important, easily available on Amazon to see what is the pH. AS, it is more important than an octa, AS octa. In the AS octa, you may be, in the modern versions, you may be able to see the limbal ischemia and the compromised vascularity. Of course, not available everywhere. Even our version of AS octa does not have this aspect of anterior segment ischemia. So simple fluorescence staining may actually help in initial stages. Simply whitening does not mean ischemia. Hemorrhage also may indicate that there is ischemia. So one has to be, and the picture may keep changing from first presentation to later stages. The clinical classification of chemical injuries is extremely important. So early stages, Ream gave a classification as to the prognosis, and later on, Hughes and Balin gave the classification. Prognosis also depends upon the extent of damage to the conjunctiva and episcleral tissue, severity of the lid burn, and damage to the intraocular structures. So the next MCQ is the basis on Dua's classification. Is it based on cornea, limbus, and lid, or cornea, limbus, conjunctiva, and lid, or limbus and conjunctiva, or limbus, conjunctiva, and lid? So the classifications, there are many. No classification is perfect. We are still searching for a perfect classification. The total area of the corneal epithelial defect, the area of conjunctival epithelial defect, the number of clock hours of degree of limbal blanching, the area of the degree of density of corneal opacification, evidence of increased IOP, and loss of lens clarity. One of the earliest classifications was Ralph's classification, where the prognosis code, the total score determines the prognosis. So each aspect was given a certain number, like perilimbal ischemia, hyperemia, chemosis, spotty perilimbal ischemia, cloudy epithelium, denudation of epithelium, and 50% loss of epithelium, stromal haze, vertically oval fixed pupil involved, so showing the long posterior ciliary arteries involved, perilimbal ischemia, complete epithelial loss, moderate stromal haze, iris details are not visible, perilimbal ischemia, 1/3 to half the circumference, sustained intraocular pressure, severe stromal haze, no iris details visible, and perilimbal ischemia, more than half the circumference. So here we can find on a total score of 0 to 3, the injury is insignificant with rapid recovery. 4 to 6 is mild with rapid reepithelialization, clearance of stromal haze. 7 to 9, moderate, moderately severe burn, complete reepithelialization takes 1 to 3 weeks. Stable pannus of 1 to 2 mm is common. But if you get a score of 10 to 12, it is very severe. There is no perforation, but slow reepithelialization, pannus, furrow from collagen-lytic activity, perforation may happen, and more than 13, it is haze, inflammation quietens after months, there is dense pannus, and perforation is quite common. Now, Hughes classification, later modified by Roper Hall, easy to remember, mild, moderately severe, and very severe. Second. So the clinical finding in mild cases, there is erosion of the corneal epithelium, faint haze, haziness of the cornea, no ischemic necrosis of the conjunctiva or sclera, moderately severe corneal opacity blurs the iris details, mild ischemic necrosis of conjunctiva or sclera, but in very severe cases, there is significant ischemic necrosis of the conjunctiva or sclera. Thorpe's classification could be in grade 1, 2, 3, and 4, a little more to remember. The grade 1, there is no ischemia, there is good prognosis. Grade 2, cornea is hazy, but the iris details are seen. Ischemia less than 1/3 and good prognosis again. Grade 3, total loss of epithelium, stromal haze blurs the iris details, and 1/3 to half of the limbus is ischemic, very guarded. And grade 4, the cornea is opaque. Ischemia is more than half of the limbus with very poor prognosis. Now, modification by Roper Hall, grade 1 and 2 are also very good. Grade 3 is guarded. 1/3 to half is limbal ischemia, and grade 4, poor prognosis. Harminder Dua's modification of chemical injuries we very often use. Here you have grade 1 to 6. Grade 1, very good prognosis, no clock hours of limbal involvement, no conjunctival involvement. Grade 2 and grade 3 also good. But here the limbal involvement is less than 3 clock hours, and grade 2, less than 30% conjunctival involvement. Each one is accompanied by an analog scale. Grade 3, more than 3, less than 6 clock hours of limbal involvement. Conjunctival involvement is less than 50%. Grade 4, good to guarded. more than 6, less than 9 clock hours of limbal involvement, but conjunctival involvement is more than 50, less than 75%. Grade 5 is guarded to poor. Here, conjunctival involvement is less than 100%, but grade 6, 100% of the conjunctiva is involved. The analog scale records accurately the limbal involvement in clock hours of the affected limbus divided by the percentage of conjunctival involvement. While calculating percentage of conjunctival involvement, only involvement of the bulbar conjunctiva, including the fornices, is considered. So here you can see, excuse me, grade 1 Duas classification, no area of limbal ischemia, no conjunctival involvement. Grade 2, less than 3 clock hours. Grade 3, less than 3 clock hours, less than 50%. Grade 4, less than 9 clock hours, less than 75%. Grade 5, you can see less than 100% of conjunctiva, and in grade 6, 100% involvement. So here's one case where there was so much. I mean, here you can see almost grade 6 of Dua's classification. And if you happen to stain the epithelium, do not find the edges. It could be complete epithelial defect because the edges you cannot find. In acute management, it is an emergency. You have to remove the offending agent, stop further damage, promote reepithelialization, promote corneal repair, minimize ulceration, reduce inflammation, and control the intraocular pressure. I think Dr. Bhaskar later will be able to tell about I think it's the e-pics which Dr. Geeta and he had coined, and we would be happy in the panel discussion. Irrigation, prompt irrigation initiated immediately, anesthetic drops and passive opening of the eyelids. Ask the patient to look in all directions, wash all the aspects of conjunctiva and cornea. Cotton-tipped applicator soaked in 1% EDTA can be used to remove line particles. Extremely important to remove all the tuna particles, otherwise they keep eluting. Evert the lids, look at the fornices, and pluck out all the aspects of the chemicals which are there. At least 500 to 1,000 ml of normal saline, ringalactate, BSS, BSS plus. Preferably avoid water because it is hypoosmolar. Diphotherine 0.4%, pH 7.4, osmolarity of 820 milliosmoles, binds alkali and acids if it is available. Till pH is of the normal range, keep checking the pH every 10 minutes with the universal pH indicator. Debride the necrotic cornea, conjunctival epithelium, subconjunctival tissues to remove the nidus of continuous inflammation and sustained release of proteolytic enzymes. It is important if you can measure the visual acuity, excuse me, pupillary reaction, examination of the facial skin, eyelids, lashes, lacrimal apparatus. With a pen light or slit lamp, just look at the epithelial loss, corneal opacification, any line particles. White eye is worse than a red eye. Limbal ischemia, clock hours of blood vessels of loss of conjunctival tissue where it nears the peripheral edge of the cornea. Fluorescent staining is important. IOP either digitally or instrumentally with tonopen. Applanation may be difficult. Posterior segment evaluation if possible under dilatation. The main importance in medical management in the acute phase is promotion of reepithelialization, tear substitutes, preferably preservative-free, with or without punctal occlusion, bandage contact lens, collagen shield may protect the ocular surface from windshield viper effect and promote epithelialization. Investigational drugs here are fibronectin, epidermal growth factor, retinoic acid, umbilical cord blood, where I think the API Center has done some randomized control trials, amniotic membrane suspension, autologous serum, platelet-rich plasma. The aim is to promote corneal repair and minimize ulceration. Ascorbate, topically 10%, systemically 2 grams QID reduces the incidence of ulceration, but no effect on established ulceration. Tetracycline reduces collagenase activity, also inhibits polymorphonuclear leukocyte activity. Doxycycline or minocycline or tetracycline can be used. Acetylcysteine, sodium EDTA, calcium EDTA can be used. Now, normally only acetylcysteine is used clinically. Now, ascorbate, 10%, and sodium citrate are extremely useful to promote prevention of collagenolisis. Now, topical autologous platelet-rich plasma eye drops, they promote epithelialization and may heal faster than standard therapy. There have been studies by Dr. Anita Panda, which has been published in Cornea in 2012. Now, the sixth MCQ is the role of vitamin C. It decreases inflammation, promotes healing, prevents collagenolisis, or promotes collagen synthesis. Now, role of topical ascorbic acid. It was, how was it prepared? 10% was loaded in undiluted form in photoresistant empty green tea vial and known to be very unstable and gets converted into an inactive form. The preparation of sodium citrate and ascorbate has also been shown in literature. One simple way is to get vacutainers, that is the blue top, put 0.8 ml of distilled water in it, invert it 8 to 10 times to get a 10% sodium citrate. Sodium citrate can help to prevent polymorphonuclear leukocyte infiltration into the site of inflammation and prevent collagenolisis because they release collagenases and elastases. Now, in acute chemical burn, there is one busy slide here when it can be useful when you have presentation within 1 week and otherwise when there is a delayed presentation. So when the patient presents within 1 week of injury, when there is suspicious areas of ischemia, you start medical treatment with intensive topical steroids and observe. You may see a reperfusion, may not need further any surgical treatment. If there is confirmed sectoral ischemia, then you may perform a tarsorrhaphy. One should have a very low threshold for tarsorrhaphy and observe, and otherwise a sectoral tenoplasty or amniotic membrane graft and permanent paramedian tarsorrhaphy. If there is total ischemia, then tenoplasty or tenon's advancement and amniotic membrane graft over the injury and central permanent tarsorrhaphy. If there is a very delayed presentation, you can start treatment with, again, topical steroids with sectoral ischemia, sectoral tenoplasty, amniotic membrane, and tarsorrhaphy. And with total ischemia, you can do total tenoplasty and central permanent tarsorrhaphy. It's very important for the postgraduates to understand the importance of tarsorrhaphy. It is not such an outdated procedure after all. Inflammation control with topical steroids is very important. Normally, the thought process is if there is epithelial defect, can we give topical steroids? Here is one condition where you have to give topical steroids, which decrease first and second wave of inflammatory cell infiltration, decrease collagenase production, stabilize polymorphonuclear leukocytes and lysosomal membranes, but it can impair stromal wound healing by inhibiting keratocyte migration and collagen synthesis. So it's not all hunky-dory with steroids, but it's extremely important whether in mild cases to give soft steroids, QID, or severe cases, prednisolone acetate, 1% hourly. Now, non-steroidal anti-inflammatory agents, preferably avoided, and sodium citrate, it's a calcium chelator, inhibits collagenase. The others are prophylactic antibiotics, cycloplegics, and anti-glaucoma agents. In surgical management, debridement, amniotic membrane transplantation, tenoplasty, tissue adhesive, alloslet. In case of bilateral conditions, as the most important thing is to re-epithelialize. Amniotic membrane transplantation in acute burns within 1 week of surface burns. How soon? I think the panel will also decide. Mild cases, grade 1 and 2 may not be needed, but when you find in second or third day in severe cases, you may do it immediately also or wait for a day or two. It can be removed 7 to 9 days. It's tested for expression of CD15, 68, 20, 57, 97. It traps the inflammatory cells, reduces the apoptosis, and induces apoptosis of inflammatory cells. It can be performed in acute, early, and rate reparative stage. It has been found in acute cases when you put when the pannus forms, it forms a nice plain, but can easily strip off the pannus. It actually, and you can see a shining cornea underneath. It has anti-angiogenic, antiseptic, promoter of epithelialization, analgesic, anti-fibroblastic properties, and keeps adhesive surface apart. It can be used as a graft or as a patch. It is our first tool to decrease inflammation, to facilitate epithelial healing, reduce scarring, and decrease vascularization. Here is one patient who had thermal and chemical injury and with amniotic membrane transplant did pretty okay. This is one case with Professor Vanati, you will remember, with hydrogen peroxide corneal emphysema. He who fell, which was about 10 years ago. It's a patient working in a dye factory, fell on a pool of dye and presented with corneal emphysema like this, was advised amniotic membrane transplantation, could not afford. And in All India Institute, and he actually melted like this within the next day when he presented to Professor Vanati, and she did a good amniotic membrane transplant. So in early stages of chemical injury, here is just a representative video, which is from a long time ago. Here, this is actually grade 4 chemical injury, or even more, you can say. A simple amniotic membrane transplant may not suffice here. Here, I have done a 360-degree peritomy. Should have done a tenon advancement alongside, but here I have done only an amniotic membrane transplant. I think the panelists will be able to tell me that in this case, there would be a necessity for tenon's advancement as well as probably for an alloslet, not just an amniotic membrane. This is a video from a very long time ago. And here you can see that it has been glued in as well as sutured at the limbus and also at the fornices. So it's important that and many times I think even a conformer can be placed there. So conjunctiva at tenon's advancement, there have been papers, I think, by Dr. Bhaskar and Dr. Geeta also, described by Tepping and Reen, suturing vital connective tissue in the orbit. All necrotic tissue is excised, followed by blunt dissection of the tenons from the equatorial region of the globe, and advancement of the tenon's flap, and getting the carefully preserved vascular tissue to the limbus. And in case of impending perforation, a thin conjunctival flap from the ipsilateral or contralateral eye or mucous membrane grafting can also be performed. Tenonplasty in grade 5 grade 6 burns. Here, this is a paper by Dr. Bhaskar and Dr. Geeta for visual rehabilitation in early cases of, in chemical injuries. So here there is a paper which shows from L.V. Prasad Eye Institute showing inferior sectoral tenonplasty following alkali burns. And here you can see that this complete ischemic area is actually getting vascularized. So it's extremely important. And after 360-degree tenoplasty followed by a penetrating peritoplasty in the later stages, you can see that the structural integrity of the globe as well as visual rehabilitation could be achieved. Now, combination of stenoplasty along with amniotic membrane transplantation. So here, 4 to 8 o'clock, you can see that there is a conjunctival necrosis and limbal failure. And what you can see is here, you can see this blue dotted line, and the necrotic areas are removed. The tenons is it's advanced here, and you can see that in the the amniotic membrane graft is attached over with 80 vicral sutures at the junction of the residual conjunctiva. And it was also anchored onto the cornea with 10-0 nylon sutures. So these procedures are extremely effective in cases of severe chemical burns. Now, tissue adhesives, they are used in small corneal perforation, whereas an emergency patch graft or therapeutic PK for large perforations, but here it has to be mentioned that penetrating keratoplasty is not a good option in the early stages. But if nothing happens, if it's a large perforation, it may have to be done, but preferably covered by amniotic membrane graft and also a tarsorrhaphy and carefully followed up because it can easily melt. Alloslet again by Dr. Bhaskar and Dr. Geeta. They have mentioned the outcomes of allolimbal epithelial transplantation in cases of acute chemical injury. And especially in cases of bilateral cases, the advantages are you get a large amount of limbal cells, and it does not need any immunosuppression because it's only in the early stages, and you only need to, it's not for a long-term effect, you just need to epithelialize. And this is an extremely useful tool that they have described. In the intermediate phase, the main goals are structural reconstruction and ocular surface restoration. So the proposed classification of epithelial transplantation for ocular surface disease, especially chemical injuries, are you can have conjunctival autograft from the fellow eye, or cadaveric or live related, or it can have cultivated limbal transplantation, which can be from the patient or from the cadaver, or keratolimbal allografts. So the management overview of unilateral versus bilateral. Grade 1 unilateral, only medical management. Grade 2 and 3, medical plus minus AMG. Grade 4, 5, and 6, medical initially, and conjunctival limbal graft from the other eye. Simple limbal epithelial transplantation, cultivated limbal grafts. Now, or cultivated limbal grafts. In bilateral cases, grade 1 again medical, grade 2 and 3 medical plus minus AMG. Grade 4, 5, and 6, initially medical, tinoplasty, cultured limbal cells or from a living relative, cultured oral mucosal transplant. In the late stages, keratoprosthesis. Now, successful management of severe chemical injuries in children using simple limbal epithelial transplantation has been described. Now, there are many, many studies, and this procedure by Professor Dr. Sangwan is a completely, it's a game changer. And you can see that now there are many, many studies here. Like we said, for alloslet, in unilateral, you can use from the other eye, or you can use from in bilateral from living relative. And so there are many, many studies here. In 2000, I think when I was in LVP in 2000, he was doing cultivated transplants. Later, I think as an epiphany, or he detected, I mean, this procedure of simple limbal epithelial transplantation, which does not cost any money, but is a complete game changer, as I said. So simple limbal epithelial transplantation, 2 to 2 mm of donor tissue divided into 8 to 10 or more pieces, placed on an amniotic membrane. It's an in vivo culture of limbal stem cells. Now there are many more studies coming in where the pieces are placed directly on a smooth corneal surface, or there is a sandwich technique, but the most commonly done technique is placing the amniotic membrane graft. Here there is a representative picture of those simple limbal epithelial transplant buttons placed on an amniotic membrane. This is in a localized case. You can also place it, it's meant to be placed paracentrally because the cell grows from there. And then if it's placed in the center, it can cause a little bit of scarring. Sometimes some mesenchymal tissue is also involved and may be present in the later stages. There can be a lot of collagen remodeling, and you can see a very clear surface in the later stages. Now, PK after autologous cultivated limbal stem cell transplant has also been described. And in 2 stages, it has been found to be better than a single stage procedure. Complications of chemical injury can be non-healing defect and melting. There can be corneal opacities, cataract formation, glaucoma, and in the late stages, phthisis also, severe dry eye because of damage to the goblet cells, lid malposition, ectropion, entropion, symbiofron formation, trichiasis, and scarring. In the late stages, visual rehabilitation, when the patient is comfortable. Now the question is, how do you rehabilitate? So keratolimbal allograft, conjunctival limbal autograft, cultured limbal stem cells, large diameter therapeutic penetrating keratoplasty, keratoprosthesis. Now the clinical presentation of limbal stem cell deficiency, how do you distinguish when you can see here, how do you distinguish a limbal stem cell deficiency? There is late fluorescent staining, stippled fluorescent staining, and in total limbal stem cell deficiency after penetrating keratoplasty, it usually, I mean, if there is stem cell deficiency and you do a penetrating keratoplasty, it's a sure shot failure. Here you can see diffuse LSCD in diffuse illumination. slit lamp and in a partial LSCD. Now, confocal images of central cornea in normal stem cell, normal cases, and also in cases of limbal stem cell deficiency. Now, basal epithelial cells, the cell size is small, cell borders are distinct, and in moderate LSCD, the cell size is enlarged, cell borders are indistinct, and in total LSCD, there is loss of normal corneal epithelial cells and presence of severe neovascularization. There could also be inflammatory cells. In early stages, we have done keratolimbal allograft from cadaveric donor tissue and transplanted to the burnt cornea under a cover of oral immunosuppression. This was one of my cases almost 20 years ago after coming out from fellowship when we did not have SLET and we took keratolimbal allografts and like Ed Holland and Thorpe's papers and covered the entire limbal surface, but not knowing about immunosuppression, it actually failed because it needs immunosuppression in a large scale. Conjunctival limbal allograft may be taken from a contralateral uninvolved eye in the cases of unilateral involvement or from living related donor in case of bilateral involvement. Cultured limbal stem cells, well, you need a clean room and you need to it needs a lot of involvement from the scientists, and it also involves a lot of funding which is needed, but it is a useful tool. You can take a small amount of limbal biopsy, grow the limbal epithelium, whether you're growing it on a scaffold. We also had done a few experiments with scaffolds and growing the limbal epithelial cells. So it can be grown in a new concept of ex vivo expansion. It's not a new concept anymore. It can be grown on a scaffold or it can be grown on the amniotic membrane. Of course, the pros and cons of biological membranes versus scaffolds is still ongoing. Now, the scaffolds have not yet been perfected that it can transport the limbal stem cells onto the cornea and then disintegrate on its own. Now, if you, there is also autologous oral mucosal epithelial cells, which a small sheet of oral mucosal transplant can be taken and it can be cultivated and this can be placed. But here I think the disadvantage is more of a vascularization and it is not the normal epithelium which grows on the conjunctiva. Xenograft transplantation has also been tried. Human endothelial sheet cultivated on the amniotic membrane has been transplanted and also the epithelial sheet. And but xenografts probably have yet to be taken on a large scale. Nasal mucosal grafts, hard palate grafts are thickest. Nasal mucosal grafts contain goblet cells. They may contribute mucus to the tear film. This is maximized and turbinate mucosal grafts, which can relieve discomfort in extreme dry eye situations. But nasal septal cartilage has fewer goblet cells, but it can add rigidity to the surface. Large diameter penetrating keratoplasty, it also transfers not only the corneal tissue, gives early visual rehabilitation, but long-term stability can be in doubt because of the severe limbal stem cell deficiency. Keratoprosthesis indicated in bilateral severe chemical injuries. And here among the panelists, we have a lot of experience with keratoprosthesis, whether it's the Boston K-Pro, the LVP K-Pro, or the MOO K-Pro, MOOKP, where more than 4 rejected grafts here that said that when they are repeatedly rejected, then there's no option but to do a keratoprosthesis. Now, you can see the Boston K-Pro, the type 1 here has the front cylinder, the corneal graft, the back plate, and the locking ring. And the MOOKP, where Dr. Bhaskar will be able to tell us, he's got a lot of experience with the MOOKP, and it's long-term. When all is lost, MOOKP comes to the rescue. Now, here the answers, to make it easy, the first 5 MCQs, the answer is C. The last one, the answer is D. Thank you for your attention.
Thank you, Dr. Sridhar, for that very comprehensive talk where you covered all the complexities of chemical injury of the eye. So congratulations, that was a brilliant talk. With that, we dive deeper into the discussion, and I invite our panelists to give their thoughts, perspective, and comments on this topic. We'll start with Dr. Bhaskar. Dr. Bhaskar, Dr. Sridhar alluded to a lot of your studies during her talk, and I'd like you to add the important pointers that the PGs should keep in mind, or any other new cutting edge, study that you have done. So over to you for your comments.
Thanks, Dr. Uma. That was a wonderful presentation. So, just to kind of make things very clear, when you're talking about chemical injuries, you're talking about two situations. You're talking about an acute chemical injury and you're talking about a chronic sequelae that you are looking at. So, when you're looking at an acute chemical injury, what you are basically trying to address is what is the extent of the injury. So, you would, at this point of time, want of better classification, at least still continue to use the DUAS as a prognosticating factor. But we have published our kind of a, it's not a classification, as it's an add-on to DUAS classification where we have labeled it as EPICS, because these are some of the factors that are there in the acute chemical injury, which you need to address. So the E stands for epithelial defect, whether it is conjunctival, whether it is cornea. The P stands for pressure, the I stands for ischemia, and the X stands for exposure. So when you're looking at a chemical injury patient, you're looking at the extent of defect, whether it is in the cornea, whether it's in the conjunctiva, and that you will follow with what has been mentioned in DUAS classification. But you also need to make sure that the scleral ischemia, if it is there, needs to be addressed. You need to look sure that the exposure, if it is there, needs to be addressed. And you need to make sure that the IOP needs to be taken care of. Because if you miss any of this, you will end up having an epithelialized surface, but a completely optic atrophy, which will end up making the patient blind. Again, when you're dealing with a bilateral injury versus a unilateral injury, your desperate measures to try to save the eye becomes even more important, because you are going to be subjecting the patient to a lifelong without vision kind of a situation if you don't act. How you act in terms of what you can offer them in the chronic phase, whether it is a stem cell based therapy with PK or you do a keratoprosthesis. And what we have realized is anybody with more worse than grade 4 DUAS classification of chemical injury, where there is significant conjunctival and a limbal involvement. DUA doesn't speak of limbal ischemia per se, because we still cannot assess the exact amount of limbal ischemia by looking at the patient on slit lamp, because some of the deeper limbal cells might still survive. So what DUA is talking about is limbal defect and conjunctival defect. So if it is more than grade 4 and it's more than 10 days since the day of injury, because when the patient presents is also important. If the patient presents at day 10 after injury, or he presents at day 30 after injury, and you are grading it as a grade 4 and day 30, that means it was probably grade 6 to begin with, and it is grade 4 at 30. So you need to know the time frame when the patient had the injury, when he is presenting to you. If it is more than 10 days and you're still dealing with a grade 4, then you have to surgically intervene, and you would probably have to surgically intervene with an amniotic, definitely. But if there is a large conjunctival and a limbal epithelial defect, you might have to supplement it with a source of epithelium, which would be what we call as allogenic limbal stem cell transplants in terms of alloslet. The idea of alloslet in the acute phase is just to epithelialize the surface. You are not talking about these cells surviving. I just want the cover on the cornea to be there so that the cornea doesn't scar, cornea doesn't melt. So the subsequent rehabilitation in the chronic phase becomes important. When Dr. Uma talked about steroids, she said that steroids can have deleterious effect in the long run because it affects collagenolisis. The time frame that we are looking at is 10 days. But we can't stop steroids in these eyes at a 10-day period. But the 10-day tells you that if the defect is still there after a 10th day, it tells you need to intervene. You need to go ahead and do an amniotic. It's not that you're going to be stopping steroid at the 10th day, but if the defect is present, you need to go ahead and do the amniotic, or do whatever it requires to get the epithelium on the ocular surface. The faster you get the epithelium on the ocular surface, the better possibility of retaining vision. So we have a couple of publications on alloslet in acute chemical injuries, which you could read up. The publication that Uma said in terms of tenonplasty. So the tenonplasty publication was as a preclude to keratoprosthesis, but that was a publication that we did before we started using allogenic slet as a treatment algorithm in our management. And the amount of patients that we've been able to avoid going down the keratoprosthesis line been much better until you start to evaluate. The idea in the management is to reach a stage where you are able to retain the anatomy of the eye as best as possible, and the possibility of functionally rehabilitating them, whether with an autologous slet from the other eye, or with an allogenic slet, or a live related slet from the donor, or requiring a PK, or if it's really bad with very severe or scarred lids, the option of doing a keratoprosthesis. So at least leave the patient with the hope of getting some vision at the end of this entire management of acute freeze.
One thing, Bhaskar, thing is not stopping steroids, of course, and people have said medroxyprogesterone, but there's another study which says that if there is a lot of ascorbic acid level in the aqueous, then the steroids may not really cause a melt. So it's important to give plenty of ascorbic acid and make sure that it's there in the aqueous. So you can, I mean, that's one way.
We're not able to hear Tinku.
Tinku, you're on mute.
Sorry. Yeah, Dr. Sridhar, there was something that you alluded to in your talk that you wanted the panelists to take up for discussion.
Yes,
So,
the image that, I mean, the video that I showed, it was a long time back video where I did a 360-degree peritomy and just put an amniotic membrane. Now, considering at this stage, from what we know, I think all of the panelists, Bhaskar, Jayesh, Vinay, Vanati, in that stage, in that case, looked like a grade 5, grade 6. There would be several surgical procedures which would be required in that patient. So how would you handle it now?
So, Dr. Jayesh, would you like to take that up?
Yes. So it's true that the thinking keeps on evolving with time, but the basics remain the same. So the essentials remain what Dr. Sridhar did, that you cannot have a bare surface or a stroma, so you need to get some kind of cover on it. So an amniotic membrane was indicated. Tarsorrhaphy is what I would always do in such kind of burns. And because it appeared that at least some part, maybe half of the area looked like there was some blanching, I would probably, if I were to do that case today, maybe combine it with a sectoral Tieden's advancement. So as far as the PGs go, I think her talk was very comprehensive. I don't think I knew even half of this as a postgraduate student. So she's covered pretty much everything that they need to know. But one comment would be that now we have a lot more data from India specifically about the causes of chemical, thermal, ocular surface burns in general. So that is something the postgraduates can read about. There's some recent literature on that. And also about what are the causes that lead on to sequelae like limbal stem cell deficiency. So some of the epidemiological data that has been coming out from good centers in India has been excellent. And that is something all the PGs should read.
Dr. Vanati, you two have a vast experience in treating chemical injuries of the eye. So if you could give your inputs that you think would be relevant to the PGs.
Thank you, Tinku. A very enjoyable talk here. And chemical injury is one clinical scenario where, as Bhaskar rightly pointed out, you need to know at what stage of the chemical injury you're managing the patient. That's something very important. So largely for postgraduate students or practitioners, it's the acute chemical injury phase when the patient comes in, or you're looking at a chronic chemical injury sequelae. So you will have to primarily address what part of the eye needs the first intervention and then move it on to the next intervention here. It's not a textbook protocol kind of a thing, as Bhaskar rightly explained here. So when you're managing acute chemical injuries, your priorities lie on a rapid epithelialization of the ocular surface. That means not only the cornea, also the conjunctiva. And I do find a lot of people who are managing acute injuries tend to forget that the conjunctival epithelium also needs to optimally epithelialize for a good, healthy ocular surface here. So that needs to be primarily attended to. And the second point is to prevent any of the chemical injury sequelae like symblepharon formations and those. So you will have to add on measures to prevent these from occurring. From there, again, it is imperative to stress upon to the patient and their attendants that it's going to be a long drawn process. It's going to be a battle requiring several interventions before you could probably do whatever or bring the surface to really acceptable, say even 30-40% of the acceptable norms. And again, in the best of hands, when you're looking at corneal rehabilitation surgeries following ocular surface reconstructions, remember when you're looking at chronic chemical injuries, the primary aim is for surface reconstruction, which will require symblepharon lysis, symblepharon management, surface reconstructions in terms of AMGs or in terms of MMGs, and in terms of managing the cicatricial entropion, ectropion, which are all present. Only after which you would look at the limbal stem cell management. And then you would look at visual rehabilitation in terms of what keratoplasty procedure or keratoprosthesis is going to be adequate depending upon the wettability of the ocular surface here. So it's a very staged interventional procedure. It's very long drawn. The prognosis is not very really enthusiastic in most of these cases, but I think chemical injuries is one of the better prognosis of the ocular surfaces diseases when you're managing them. Assessing the chemical injuries, and this is something which the postgraduates will have to go and update themselves upon.
Thank you, Dr. Vanati. Yeah,
As
Dr.
opposed to SJS and OCP, Vanati.
Yes.
I mean,
this is one of the better ones when you're dealing with ocular surface. Yeah.
Be nice, yeah.
So, Dr. Pillai, would you like to add anything to the discussion?
Yeah, I mean, the entire, gamut of managing chemical injuries are covered beautifully. But then one small point I would like to add is, as a postgraduate or as a primary caregiver, the person will be, facing the real acute ones, within hours of injury coming to the emergency room or your clinic. So that is one real ocular emergency which we have to manage. We start treating even before we really get a detailed history. Okay, once we know the patient's vitals are stable and there is no open globe there, especially in kind of blast injury or any of those things in a factory, we start washing, wash. Okay, so that is one important point here. Okay, might help in preventing the progression or the continued worsening of the ocular surface damage, especially if there are any particles or chemical remnants in the conjunctival sac. It has to be looked for and removed. If it is a child, don't hesitate to look under anesthesia for the particles. And once that acute part is over, then comes the rest of the management. The epithelialization, controlling inflammation, everything has been in detail mentioned by Dr. Uma and the rest of the people.
Yeah. So thank you, Dr. Pillai. So if Dr. Sridhar, anything else that you'd like to be taken up for discussion? Otherwise, I think your talk was very comprehensive. You've just covered
Thank
everything.
you, Tinku. I think that's it.
Yeah. Okay. So with that, we come to the end of this episode of Guru Sangam. I first of all thank all our panelists for enriching the discussion with their very insightful comments and helping our audience get a deeper understanding of the subjects. I thank all our speakers for imparting a wealth of knowledge to our PGs. All the talks were excellent, and I congratulate the speakers for the wonderful talks. I also thank all the people who've joined us today, this Sunday morning. I'm sure it was a Sunday well spent, and I hope that this session has been useful for the PGs. Just to tell you more about Guru Sangam is going to be a series of over 80 lectures over the next 2.5 months. And today at 6 p.m., from 6 to 8 p.m., we have 3 more very insightful talks on different aspects of cornea. So I request the audience to again log in at 6 p.m. for some great cornea conversations. So with that, thank you once again to the panelists, the speakers, and the audience. And look forward to seeing you again in the evening. The audience, I look forward to seeing them in the evening again. And wish you all a very wonderful Sunday. Thank you.
Thank you, Tinku.
Thank you.
Thank you.